External auditory canal comprises the outer ear, middle ear, is a narrow area in between the pinna, the tympanic membrane to the inner ear, and it is found by this cochlea of the labyrinth, cochlea, and a rarefaction of the air molecules, and they hit the tympanic membrane, and the pinna or the auricle, they act as a funnel of these sound waves, and animals then they can move the pinna to collect the sounds, and this tympanic membrane will vibrate. It acts as a resonator. It will vibrate, and this vibration is transmitted to the oval window by means of these small bones of the middle ear, malleus, incus, and stapes. A fantastic ossicles, bony ossicles, malleus, and the middle ear contains two small muscles, tensor tympani and stapedius. Tensor tympani. By fifth nerve and stapedius by the facial nerve, and it is connected to the nasopharynx by means of pharyngotympanic tube or auditory tube to equalize the pressure outside. Now there is a term, that is the impedance matching. Impedance matching. Matching.
Disconnected. Connected.
Impedance matching means that is the energy is lost when the wave traverses to different media from air to
Disconnected. Connected.
watery part, and there is loss of energy, and the ear has the device to save as much as the energy possible.
Disconnected.
Possible.
Connected.
It is called impedance matching.
Disconnected.
When the sound wave from the ear is approaching the liquid media, then most of the energy will be lost due to change in the physical properties, their density, viscosity also. And there are the mechanism to conserve much of the energy that may be lost. It is called impedance matching. And this malleus, incus, and stapes, and they form a lever system. So there is the gain of 1.3 tympanic membrane. You can remember in your textbooks of physics, lever system or hydraulic pressure, how it is possible to increase the pressure by the ratio of the area over which they are operating. Yeah. If you consider the workable area, that is increased, and in this way 60% of the energy can be conserved when the frequency is around 3000 Hertz. So much of the energy is conserved. It is called impedance matching device. And the natural frequency of the external auditory canal is close to this value. So there is every attempt by the nature to conserve energy as much as possible, that they are not lost. 60%, around 60% of the energy is consumed. So the frequency is around 3000 Hz. Yeah. So tympanic membrane behave as a resonator. And there is amplification of 1.3 times by the liver system of Malleus, incus and stapes. And in your text, anatomy text and physiology text, you will find how they are disposed, in which axis they are vibrating. Now this oval window ends in there is the scala vestibule, and this cochlea of the inner ear is responsible for this hearing on either side, and it is like that of the snail, and then there is 2 and 3/4 times of rounding around an axis, that is called modulus. And if you take the cross section in every good text, there is these figures that are given. They contain 3 spaces or scala vestibuli, scala media and scala tympani, divided by Rischner's membrane or vestibular membrane and the basilar membrane. Scala vestibuli, scala tympani is the cochlear duct or scala media, and it is the basilar membrane, over which there is the organ of Corti. Organ of important for the examination, frequently comes in university exam as short notes, organ of Corti. Then you have to give a simple figure and to explain what is going on. And the length of the cochlea from the base to the apex, they are placed at the lateral side. If you can see from the front side, and the apex on the lateral side, and 35 millimeter is their length, 35 millimeter. And this is the basilar membrane, over which is the organ of Corti. And organ of Corti, they contain this type of structure, rods of Corti or pillar cells. This type of structure we will see. It is the rods of Corti or the pillar cells. And this space between, it is the tunnel of Corti. And on the medial side, and here this is the, if you consider the afferent fibers, they are going on. Spiral ganglion of the cochlea, bony part, and here it is the stria vascularis, and surrounding this is the spiral ligament. And there are 4 rows of cells. One is inner hair cell, and these are the outer hair cells. And they are surrounded by cells, phalangeal cells, supporting cells. inner phalangeal cells, outer phalangeal cells, and they are connected by the tight junctions. So there is no communication from this part to this part. That is, the base of the hair cells are bathed in the perilymph of scala vestibuli and scala tympani, perilymph. And this scala media is from this, there is the endolymph. And their concentration of these electrolytes do differ. And it is potassium rich. And potassium is more in this. And it is sodium rich. And their coil structures and scala vestibuli and scala tympani, they communicate at the apex by a narrow opening that is called helicotrema. A simplified diagram, if you consider, it is the footplate of the stapes and it is helicotrema, scala vestibuli, scala tympani, and it is the oval window, and it is the round window, and covered by the secondary tympanic membrane. Tympanic membrane, you are familiar with it forms the lateral wall of the middle layer, where there is the handle of the malleus do joins, and it is the secondary tympanic membrane that was the round window, and they are in communication at the apex of the cochlea by a narrow aperture. It is called helicotrema. And this potassium rich fluid is similar to that of the intracellular fluid, and it is secreted by the stria vascularis, and this potassium will reach via the supporting cells, numerous supporting cells, and it is the inner phalangeal cells by means of red inner phalangeal cells, and these are the outer phalangeal cells. Number of the inner hair cells is 3500. Reliable textbook. And outer hair cells 20,000. And these hair cells, everywhere is the receptor cells. Besides the cochlea, there are other sites of hair cells. Semicircular canals. There are 3 semicircular canals in 3 planes. In space. In parallel, they are semicircular canals. And there are some swellings on one side. It is called ampulla. And there is a receptor organ called crista ampullaris. And that contains the hair cells. And they are responsible for rotational acceleration. And you have concept of rotational acceleration. Suppose I can move in this way, and it is rotational acceleration, or in this way, they are the rotational acceleration, or in this way, rotational acceleration. Acceleration, ত্বরণ, এই ত্বরণটা এই বোধোদয় হয়, এইগুলো হয় ইচ্ছার সাথে। Rotational acceleration. And there are linear acceleration in the horizontal plane and in the vertical plane. And they are done by utricle and saccule. cuticle and secure. Horizontal plane and it is the vertical plane. They are disposed in such a way. They are disposed in such a way so they can alert the individual of that acceleration. Suppose I am moving quickly to one side or by this side, or I can go down the stairs, or in the lift we can go up or come down, and in that case when it is in the same horizontal plane, it is the utricle that is responsible. They are disposed in such a way, and these organs are called macula. And they contain hair cells and surmounted by the hair cells by a membrane. It is called otolithic membrane. Otolithic membrane, because it contains otoliths or ear dust particles. Otoliths. They are formed of calcium carbonate crystals. Calcium carbonate crystals, and their density is more that of the in between fluid of the otolithic membrane, and these hair cells are disposed, and with any movement, there is the movement of the ear dust is to some extent different that of the surrounding fluid, and that is responsible for opening of mechanosensitive channels. And in the crista ampullaris, there is a structure called cupula, C-U-P-U-L-A, cupula. And they close, almost close this part, that is the ampulla. And their relative movement on either side give rise to some form of stimulation. When it is towards the ampullary or medial side, then there is stimulation. When it is opposite to that, that is inhibition. Suppose when I am moving in this way, one side becomes activated and the other side gets inhibited. In this way, they give information. Now we are concerned with hearing, and hair cells are present everywhere, and basic plan is the same, that the hairs are exposed to endolymph and the basal part is exposed to, there is the perilymph, and these hairs or stereocilia or in some stereovillia they are called, and they contain the mechanoreceptors. There are in the hairs of the, that is the ear of cochlea, there is no kinocilium. They are all stereocilia. Elsewhere there is a kinocilium. Kinocilium is a true cilia. Kinocilium is a true cilia. It has a club-shaped end, and the structure is similar to non-motile cilia. Non-motile cilia. You are all familiar with the structure of cilia. The peripheral doublets, and at the center there is another doublet. 9 peripheral doublets, and the center is the doublet. When they are motile, they are dependent upon the dynein molecular motor. But here it is non-motile. And all others are stereocilia. But they are not true cilia. And they gradually decrease in 30 to 150 number of cilia in this. But in case of, there is the cochlea, this cilia, kinocilium is not there. It is only the stereocilia of made of actin, and they are surrounded by different types of non-muscle myosin, and their movement is responsible for the generation of action potential in the action potentials is not produced by the hair cells, directly, but they on depolarization they release some synaptic transmitter by means of which there is initially there is generator potential and action potential is do produced. Depolarization, and when it is the opposite direction, and it is hyperpolarization. Depolarization and it is a hyperpolarization. And why I am speaking is extremely easy thing and a silly matter, I do admit, but you have to maintain the discipline. You give some digital presence and then become absent, it should not be. Absenteeism in classes, lecture classes is a problem, and it was discussed in the meeting that was present in the university. And they do not think how to manage this problem, because there are different alternative sources of learning. In addition to the library, you can challenge me. Do you know what are the number of books they are present? Different subjects. So why we should come to you? We go to the library and learn from the books much better than you. I do admit you can. Similarly, the internet has given the facility to learn from the home. But if this is continued, then there should be some decision should be made. In this institution, in my class, there is a tendency to give the presence and then leave. It should not be. You can meet the principal and that we are too intelligent and the classes subject discussed in the class are too silly, so that we can learn from outside. What is our utility to go approaching those half-learned man or quarter-learned man or simply ignorant men they are present? But the problem will remain, because you have to appear in the examination. There should be some elements, open energy systems like to examine your papers also, and it will remain. So very difficult to solve this problem. But the human brain can be solved with problems without any flesh and blood in near future, I think. Everything will be done by the machine. But you are not approached up to that limit. So you have to attend the class. At least do not cheat us. That is the, now we have considered something about how the hair cells do this depolarization and repolarization. Everywhere, not only in the inner ear of the hearing, everywhere it is the same hair cells. And whenever bending of the cilia to the taller hair cells, and in that case there is the opening of the channels, opening of cation channels, potassium channels, because occurring in the endolimb, potassium channels, they will open. And there are some structures called tip links, TIP links, tip links. And when they are bent in this way, then there is some stretching spring-like structure, and there is opening of this type of channel. And potassium and calcium ion can do enter. And there is depolarization. And in the basal part, there is this nerve fiber. And they will have neurotransmitter probably glutamate are released, and from synaptic junction, and then they will initially depolarize, then the action potential do generate there, and they will carry the impulse. It is the basic mechanism. Now, when there is no stimulus and there is a molecular motor, that bring this channel towards a lower junction, so that toward the lower junction, so that this tension will be lost, and there is again closure of this channel, and the resting condition is restored. And in the endolimb, and you can think that what is the purpose of the nature to make this. Suppose it is the endolimb and it is the perilimb, and there is a potential of, it is not only potassium rich, but it is 85 plus 85 millivolt, positive plus, and within the cell it is minus 60 millivolt. Clear? In the endolimb, that is secreted by the cells of the stria vascularis, and their concentration is much more than that of the perilimb, and here the concentration is suppose 150 millimole per liter, and it is perilimb, suppose it is potassium is 4 millimole per liter, and there is no communication between this endolimb containing site and the perilimb containing site. This cochlear duct or scala media is continuous to membranous labyrinth everywhere. They are continuous structures, and their formation is from the stria vascularis. That are special structure that we discussed at the lateral wall, and they are rich in sodium potassium ATPase, and also special that is the molecular motor, there is this channel protein that secrete potassium ion, and they are formation, and they are circulated by endolymphatic duct into the venous system. Now this difference, suppose plus 85 and minus 60, that is 145 millivolt potential difference is sufficient for entry of potassium ion. Presence of potassium is there. It is the only exception in the body, I think, where this potassium is the depolarizing ion. In nerve and muscle, you have learned that is the entry of the sodium ion is responsible for depolarization and generation of action potential, spike potential, but here it is potassium ion. Probably it is due to this smaller size of the potassium hydrated form. Affinity for water is much less in potassium than in sodium. So their effective molecular diameter of potassium ion is low, and it is a quick process. We are exposed to different types of sounds continuously. So this potassium ion can do enter quickly, within a very small interval, and do have this depolarization. And in this way the hair cells, and it is possible when it will bend in this way, then it is possible. And the hairs are disposed in such a way, it is better understood. Suppose in cases of cristae ampullaris, so that when one end on the one side is depolarized, other side becomes hyperpolarized. That is the one side is stimulated, other side is inhibited, and it gives the true information to the brain. That is what is the acceleration that is going on. Auditory nerve. Auditory nerve, they contain 32,000 or so afferent fibers. Afferent fibers. And 90 to 95% supplies the inner hair cells. Inner hair cells. Inner hair cells. And only 5 to 10% supplies this outer hair cells. Outer hair cells. Afferent fibers. And inner hair cells are the cells that are primarily responsible for our perception of hearing. Perception of hearing. And the outer hair cells, they respond to sound. Their functions are to some extent different. The tectorial membrane that originates from the limbus, and it is a thin, viscous but elastic structure. It is disposed in such a way that it has contact with the hairs of the outer hair cells, but maintains some distance from the inner hair cells. Suppose from the limbus, you will find in the group text that if it is the limbus and it is the tectorial membrane. And in this case, these hairs of the outer hair cells, they are embedded in the membrane. And there is the reticular lamina. It is the tectorial membrane. And they are all placed over the basilar membrane. Inner hair cells, there is the rod subcorti. And the inner hair cells, the hairs to some extent distance from this. It do not touch this. These are the outer hair cells and the inner hair cells. And it does not touch the tectorial membrane, but their hairs are embedded in the tectorial membrane. And these all structured together over the basilar membrane. It is the tunnel of Corti. They form the organ of Corti. And whenever there is some movement up or down in response to the movement of the foot plate of the stapes, then there is alternate, that is the depressing and elevating response, or down up movement of the basilar membrane. Then there is this movement of these hairs, because both tectorial membrane and basilar membrane, they move on the same side, but they are in different axes. So whenever there is movement, there is some shearing motion that is responsible for bending of the hair, and there is a formation of, there is a change in the membrane potential. Depolarization when it goes down, and hyperpolarization it goes up, and it is due to this action of this hair cells. Now the major number of cells, afferent fibers, they will supply the inner hair cells. But the minority supplies the outer hair cells. Both are sensitive to sound. Besides this, there are the efferent fibers. Efferent fibers are also, you are familiar with the visual system. In the lateral geniculate body, 20 to 25 fibers are from the retina. The remaining fibers are coming from other sources. Similarly, in this case, there is the olivocochlear bundle. olivocochlear bundle coming from bilaterally from the superior olivary nucleus. Superior olivary nucleus. And from the efferent. And they supplies primarily the outer hair cells. Primarily by the outer hair cells. So, and they liberate acetylcholine and they try to hyperpolarize this outer hair cells. And what are the purpose? It has some control over the outer hair cells. Inner hair cells are not contractile, but the outer hair cells are contractile. They contract with depolarization and they relax with hyperpolarization. And there is a specialized contractile protein here that is called prestin, P-R-E-S-T-I-N. Prestin. And that is doing this function very quickly. You are familiar with the contractile proteins like actin and myosin. Actin and myosin, they are present within the stereocilia of this hair cells. But when these outer hair cells, they require contraction and relaxation quickly. There must be some protein, and that is called prestin. They have some role in this. The outer hair cells, they can do contract. During depolarization, they contract, and during hyperpolarization, they relax. And they are going on continuously. And they have some control. Now the basilar membrane, their length is 32 millimeter. Basilar 32 millimeter length. As you proceed from the base to the apex of the cochlea, their dimension increases. In reliable text, you will have some figure, is the base and it is the apex of the cochlea. It is stapedial end and it is at the apex near the helicotima. And in this case, there is increasing. And they contain different types of fibers. And they are not under tension. Suppose they are above the vestibule, there is scallop vestibule. They are not under tension. And basilar membrane is also not under tension. But the fibers, they are disposed in such a way, and they have the physical properties. There is the basal part. They respond to high frequency stimuli. And the apical part, there is a wider and they low frequency stimuli. The frequencies we can perceive, it is 20 to 20,000. We cannot have our perception beyond this. That is less than 20 and it is 20,000. The tuning fork we are using in the laboratory, suppose it is 256 or so. So it is the audible range. In the basilar membrane, their physical properties is that not only physical properties of this basilar membrane, but the hair cell structures and microstructures, they are also to some extent modified. So the hair cells of the basal side, stapedial side, they respond to high frequency stimuli, and the apical part, they respond to low frequency stimuli. Traveling waves. Traveling waves. You will find in the text this type of figure. Here is repeated movement in response to the approach of the alternate condensation and rarefaction, and they can be disposed sine wave pattern in between. Sine wave pattern, repeated pattern, and in this way there are different types of, that is, these waves are produced, and when it is produced in this way. Suppose in this case it is 5,000, and in this case it is 100 or so. It is the stapedial side and it is the apical side. And they rise and there is an abrupt fall, and at that point there is the maximum pressure and there is depression, and the hair cells will be stimulated at this point. It depends upon the frequency. So the basilar membrane is an analyzer of frequencies or pitch. You are familiar to musical sound. You have learned in the higher secondary courses or other courses, sophisticated courses. এবং যেখানে তোমাদের পাণ্ডিত্য অনেক বেশি হয়ে গেছে এবং যার ফলে তোমরা আমাদের উপেক্ষা করতে পারছো। I am happy for that. And in that case, you have seen there are these types of waves are there. And there is intensity of three qualities, three attributes or features of the sound. One is intensity. Another is, there is the pitch. Another is timbre or quality. And the intensity depends upon, on which factor intensity depends upon, কার উপরে নির্ভর করে, এটাকে বলে বাংলায় বলে তীব্রতা, তীক্ষ্ণতা এবং কোয়ালিটি বা গুণ বা এই অর্থ। বুঝতে পেরেছ? তীব্রতা কার উপর নির্ভর করে? হ্যাঁ, যখন সাউন্ড এনার্জি বেশি থাকবে, এনার্জি টিউনিং ফর্ক তুমি আস্তেও বাজাতে পারো, যেমন আমি ওখানে রাবারের প্যাডের উপরে দিয়ে খুব জোরেও বাজাতে পারি। Whenever there is more movement of this prongs, এই রোল নাম্বার 35, এই তুমি সামনে এসে বসো, ওঠো, সামনে এসে বসো। আবার আরো সামনে, হ্যাঁ হ্যাঁ, এখানে, হ্যাঁ ওইখানে, হ্যাঁ, আইদার সাইড ইজ ফ্রি। কারণ এই আজকে আমার উপরে উত্তেজিত হয়ে রইল, এর লিম্বিক কর্টেক্স আজকে কাজ করবে, এর আমার উপর ক্রোধ বাড়বে এবং তারপরে ঘুমের অসুবিধা হবে। এটা ফিজিওলজির মধ্যেই পড়ে, বুঝতে পেরেছি? লিম্বিক কর্টেক্স এরকম অ্যারেঞ্জমেন্ট আছে যে সেখানে রিভারবেরেশন হয়। একটা লোকের উপর ক্রোধ হলে সে যেতে চায় না, সেটা কারো ক্ষেত্রে সেটা কয়েকদিনে চলে যায়, বুদ্ধিমান লোকদের কয়েক মিনিটে যায়, আর তাদের যারা মূর্খদের তাদের যেতে চায় না, অনেকে বছরের পর বছর লাগে, 1 বছর পরে প্ল্যান করে খুন করে। তার মানে কি, কোনো সময় ওই সময় ক্রোধের উৎপত্তি হয়েছিল কোনো ব্যবহারে, বলে আমি ওকে দেখে নেব, তারপর দেখবেন এই জন্য মাঝে মাঝে দেয়, 1 বছর পরে তাকে পেয়ে খুন করেছে। কাজে এ আজকে আমার উপর একটু বিরক্ত হয়েছে, এর ওখানে গিয়ে কি একটা পরিকল্পনা ছিল, সেটা আমার জন্য মাটি হয়েছে। এই জন্য লিম্বিক কর্টেক্সটা তুই ভালো করে, স্যার তো ক্লাসও নিয়েছে, তুমি সেটা সম্বন্ধে একটু দেখে নেবে, সেগুলো দেখলে আমার উপর রাগটা একটু কমে যাবে তোমার, বুঝতে পেরেছি? এই জন্য ও রাগের থেকে ও পিছনে গিয়ে বলছে আজকে এই লোকটাই যে কথা বলুক আমি শুনবো না, কি শুনবো? এবং তার জন্য এই যে তোমার ইফারেন্ট ফাইবার রয়েছে, এটা হচ্ছে অলিভোকক্লিয়ার বান্ডেল, and it has control over the outer hair cells so that you can reject যে আমি এর কথা শুনবো না। হ্যাঁ, এই Everything is in the physiology, good or bad. So if you go through physiology text, you will find pleasure. Physiology text, you can find pleasure. Then everything you can explain yourself, what is going on. Now, so this is this amplitude. This amplitude, that is this amplitude. The amplitude will indicate this loudness, amplitude. And the pitch primarily depends upon the frequency. Frequency, that is, it depends upon the wavelength or frequency. And this, so, and whenever there is a natural sound, there is a combination of sound. You are familiar in the physics text, Fourier analysis. Every complex sound can be analyzed into the tones or pure frequencies. In the tuning fork, that is 256. Whenever it is 256, then it is the fixed. It is made in such a way, if you strike forcefully, there will be increase in the movement of the prong, and there will be increase in the amplitude. And whenever there is increase in the amplitude, then there is, everything is the same, but only increase in the amplitude. Then it is higher than this, then it will be louder. But the pitch remains same. But pitch, to some extent, is a subjective phenomenon. It depends upon the loudness, of course. Yes. And timbres means, in the natural sound, there are some tones. There is a primary tone, and there are overtones, harmonics. The number of harmonics or other qualities, that is a part of the physics. It determines its quality, by means of which you can differentiate the sound emanated by different musical instruments. The pitch is the same, but you can differentiate. Average male voice is low pitched. Suppose it is 150 or so. And average female voice is to some extent high pitched. 275 or 250, it goes to 270. Now, in physiology text, you are familiar with the term decibels. To indicate the loudness. It is a comparative scale. And the intensity depends upon the pressure, maximum pressure that develops. Root mean square pressure, or simply this pressure, sound pressure level down here. And it is the bell, and 1/10 of a bell is a decibel. So this is the last part of our discussion for this day. That is, the bell is equal to log to the base 10 of intensity of any sound by intensity of the standard sound. As it is related to that of the square of the pressure. So it is 2 log, that is the pressure of the sound and pressure of the standard sound. And standard sound is commonly taken as, that is the just audible in a normal individual. It is 0.00204 times. And when it is expressed in decibel, then it becomes 20 of this decibel. So 0 decibel is not the absence of sound, it is equivalent to that of the standard sound pressure level. So it is from 0 value to you take 160. Onwards, it is harmful to the ears. Continuous exposure of the extremely loud sound is harmful to the ear in the sense that it will damage the hair cells. It will damage the hair cells. Suppose if it is 20 value, it is whisper. 65, this value, normal conversation. And in this way, when it is 120, it will cause discomfort. You will find this type of figure in your test. Time will not permit you for this discussion. I am stopping here.
Specific function. Then we have discussed about a nuclear column which is in the medulla. ঠিক আছে, serving the special sense of taste, sensory modality একটা neuron. কি নাম? একটা elongated nuclear column in the medulla, নাম হচ্ছে solitary nucleus. ঠিক আছে, nucleus of the tractus solitarius or solitary nucleus, ওটাকে NTS বলা হয়, NTS, nucleus of tractus solitarius or solitary nucleus. তো nucleus of tractus solitarius এই নামটা মনে রেখো, এই নামটা মনে রাখাটা ভালো, তার কারণ overlying this nucleus you will find a tract, nerve fibers you will find, like the spinal nucleus of the trigeminal nerve, যেখানে তুমি একটা tract পেয়েছো overlying the nucleus. Solitary nucleus is like that. Now it is a sensory nucleus. So it might seem to you that there is no order in the disposition of the different nuclei within the brain stem. একটা disorderly organization এরকম মনে হতে পারে, but it is not so. Remember, when the nature is pressing something to serve the human body, there must be order. There must be order. Orderly disposition আছে, ঠিক আছে? তাহলে অর্ডারলি কোথায় চলবে? কোথায়? হ্যাঁ, না ওয়াশরুম যেতে হবে না, তুমি যাওনি কেন ইন বিটুইন ক্লাসেস? You go to the washroom and leave the class. I will not allow you. You have given your percentage, that's all. At the beginning of the class, I will not allow anybody. You may leave the class with your bag and baggage. Please. I don't need people like this. Not finding time between the classes. অচ্যুত স্যার চলে যাওয়ার 7-8 মিনিট 10 মিনিট পরে আমি ঢুকেছি। You may leave the class with your baggage. No harm in that. I don't need people like that. So many students are not there. Remember, there is order, orderly disposition to begin with chilo. Later on, that order seems to be broken down. পরে মনে হচ্ছে যে order নেই, but still some sort of order is there. You will always find when a motor and a sensory nucleus is there side by side, the motor one will be medial, the sensory one will be lateral. That order will be there. কোনো একটা particular cranial nerve যখন তুমি motor nucleus পাবে, sensory nucleus পাবে, you will always find at that level of that cranial nerve, the motor nucleus is lying medial, sensory nucleus is lying lateral. ঠিক আছে? That order will be retained. তাহলে initially there is order. Now what is that order? What is that orderly organization as the brainstem is growing and developing? This one should know. Basic elements of that orderly organization. That order, to have details, to get details about that order, you need to go through the development of the brainstem, which is outside the purview. তোমার সিলেবাসের মধ্যে নেই বা তোমার পড়ার দরকারও নেই, কিন্তু বেসিক কয়েকটা জিনিস তোমাকে জানতে হবে। Now, as the brainstem is developing, especially the rhombencephalon, pons and medulla, where we are finding most of the cranial nerve nuclei. Third and fourth we are finding in the midbrain. ঠিক আছে? Now, in the midbrain, that order will also be followed, but third and fourth nerve nuclei, they are relatively simple. Third nerve nucleus, দুটোই নিউক্লিয়াস আছে, একটা এডিঞ্জার ওয়েস্টফল lying dorsolateral to the motor nucleus of the third. Somatomotor nucleus এর laterally আছে, dorsolaterally visceromotor nucleus. That is also important. Trochlear একটাই নিউক্লিয়াস আছে, কাজেই অন্য কোনো রিলেশনশিপ নেই, ঝামেলা নেই। But as we go down the brainstem, enter the pons and medulla, we are finding the cavity of rhombencephalon is not like aqueduct of Sylvius. It is not like a capillary tube. It is behind the pons and the upper open part of medulla, where we find rest of the cranial nerve nuclei. That means from 5th to 12th. We find there the cavity of rhombencephalon lies behind the pontine substance and the medullary substance. ঠিক আছে, এইটা কিন্তু প্রথম মাথায় রাখতে হবে, কারণ তোমার তো ব্রেন হচ্ছে বা ব্রেন হয়ে গেছে। আচ্ছা, তাহলে if I draw a diagram of that part of the brainstem, pons and medulla, very simplified একটা diagram যদি দেখাই, that diagram will be look like this. That diagram will be looking like this. This is the fourth ventricular cavity. Here will be lying the cerebellum. Cerebellum নিয়ে আমাদের কোনো চিন্তা নেই, আমি সেটাও দেখাচ্ছি না। Dorsally will be the cerebellum. It is a cross section through the pons at any level. তুমি পন্সে যদি সেকশন করো, এই রকম দেখতে লাগবে, more or less এই রকম দেখতে লাগবে। এই রকম মতো দেখতে লাগবে। And upper open part of medulla will be looking more or less like this, a section, cross section. Dorsally will be the fourth ventricular cavity. This is the fourth ventricular cavity, and further dorsally will be the cerebellum. Cerebellum niye amader kono jhamela nei, because we are discussing with the brainstem. Now, this thing is developing from the neural tube, the cavity, the element of the hindbrain, cerebellum, everything is from the neural tube. এই বিষয়ে কোনো সন্দেহ নেই। Neural tube, as you all know, has got 3 zones. A zone facing the ventricle, the periventricular zone or the ependymal zone, a very thin zone around the ventricles. ধরো এইরকম একটা thin zone আছে around the ventricles, a thin zone around the ventricles. Outside that zone, in the brainstem, in the part of brain with which we are discussing, we will be finding the mantle zone. Mantle zone packed with neurons, which we find also in the spinal cord. Mantle zone is represented in the adult spinal cord as the spinal gray matter. তাই না? Mantle zone মানে gray matter, neurons and their dendritic processes. তাহলে ধরো এই জায়গাটা হচ্ছে সেই mantle zone, একটা huge area, mantle zone for the lodgement of the neurons and their dendritic processes, neuronal cell bodies and their dendritic processes. Then a peripheral marginal zone, a peripheral marginal This is marginal zone, marginal zone, marginal zone, and this is mantle zone. This is mantle zone, mantle zone, mantle zone. This is mantle zone, packed with neurons, neuronal soma, and the dendritic processes. Now, as the brainstem, this rhombencephalon, or for that matter the midbrain, is growing and developing in the embryonic and fetal life, we will find changes in the mantle zone. We will be finding a plate developing here. একটা plate এখানে develop করবে. A plate is developing here. Plate by একটা column like this. A column is developing like this. এই রকম একটা column তৈরি হবে on either side of the midline, very much within the mantle zone, very much within the mantle zone. এরকম একটা column তৈরি হবে. Column of neurons. Initially এরকম একটা simplified column হবে. Column মানে কি বলতো? এটা তো ক্রস সেকশনে দেখছো, তার মানে এরকম কলাম on either side of the midline. ঠিক আছে? Just lateral or dorsolateral to this column, huge column running along the long axis of the rhombencephalon and the mesencephalon. Midbrain, hindbrain দিয়ে এরকম একটা লম্বা column দেখবো in the mantle zone. Lying dorsolateral to that column, we will be finding another column like this. আমরা আরেকটা কলাম দেখতে পাবো এরকম, আরেকটা কলাম দেখতে পাবো এইরকম, just like this, another column will be there. Now the neurons in this column are somewhat different in structure and function from the neurons in this column. এই যে দুটো কলাম আমরা দেখতে পাচ্ছি laid down side by side, the neurons in the lateral column are looking somewhat different than the neurons in the medial column, and functionally they are also different. The lateral one, this column, is being called as the alar plate. This is being called as the alar plate, alar plate, alar plate, alar plate, and this will be called as the basal plate. এই যে কলামটা medially, it will be called as the basal plate. It will be called as the basal plate. মানে আমি আলটিমেটলি ফুল ফ্লেজেড ফর্মটা তোমাকে দেখাচ্ছি, কিন্তু ইনিশিয়ালি কিন্তু এরকম থাকে না, গ্র্যাজুয়ালি এই দিস থিং আমি ফাইনাল ফর্মটা দেখাচ্ছি। এই ফাইনাল ফর্মটার আগে কিন্তু কিছু ফর্মস আছে, আমি সেগুলো স্কিপ করেছি। ফাইনাল ফর্মের আগের ফর্ম দেখবে কিরকম, আগের ফর্ম হচ্ছে এইরকম। This is the ventricular cavity. This is the basal plate. These are the alar plates. This is the ventricular cavity. এটা হচ্ছে ventricular cavity. এটা ventricular cavity. This is the ventricular cavity. Triangular. This is the ventricular cavity. Triangular. This is the alar plate. These are the basal plates. তাহলে দেখো alar plates. These are like wings. These are like wings. Dorsolateral যে প্লেটস আছে, these are like wings, সেই জন্য এদের বলা হচ্ছে alar plates। ঠিক আছে, তাহলে laterally plates are alar plates. The neurons are different in the basal plate, alar plate. Now upon foundation of these columns, এই columns গুলো তৈরি হয়ে গেল, further differentiation will be taking place in the basal plate, alar plate. Basal plate, alar plate আমরা further change দেখতে পাবো। What change we will be finding? We will find each of these columns will be broken down into multiple columns. এবারে এক একটা কলাম থেকে মাল্টিপল কলাম আমি তৈরি করব। তাহলে এই কলামটাকে ভাঙবো, আমি ভেঙে আমি দেখব এখানে এইরকম তিনটে কলাম তৈরি হয়ে গেল। এই একটা কলাম, এই একটা কলাম, আবার এই রকম একটা কলাম, এই একটা কলাম। তাহলে এই একটা, এই একটা, এই একটা, তিনটে কলাম অন আইদার সাইড, এরকম তিনটে কলাম দেখব। তাহলে নিউরনস ইন দিস থ্রি কলামস, ইন দিস কলাম ধরো বেসাল প্লেটে যে নিউরনস গুলো আছে, they undergo differentiation and reorganize themselves because each neuron in the basal plate has to serve a definite function. কাজে যে নিউরনস গুলো প্রথমে প্রিমিটিভ, সবাই একই রকম দেখতে উইদিন দ্য বেসাল প্লেট, গ্রোথ অ্যান্ড ডেভেলপমেন্ট হচ্ছে তো, কাজে দ্য নিউরনস উইল স্পেশালাইজ ইন দেয়ার ফাংশন, ঠিক আছে, অ্যান্ড দে উইল বি অ্যাসেম্বলড ইন সেপারেট কলামস। তাহলে এই যে জায়গাটা ছিল, এই যে জায়গাটা ছিল বেসাল প্লেট, টু বিগিন উইথ সব নিউরনস একরকম ছিল। এই কলামটার কি নাম? বেসাল প্লেট। নিউরনস গুলো কি? মোটর নিউরনস। সাবসিকুয়েন্টলি এই মোটর নিউরনস, দিস মোটর নিউরনস আর ডিসাইডিং দ্যাট উই হ্যাভ টু সার্ভ ডিফারেন্ট ফাংশনস দো মোটর ইন নেচার। লেট আস রিঅর্গানাইজ। রিঅর্গানাইজেশনের ফলে পরপর সিরিয়ালি, সিকুয়েন্সিয়ালি, মিডিও ল্যাটারালি তিনটে কলাম তৈরি হয়ে গেল। তিনটে কলামের কি নাম হবে? এই দেখো, সব থেকে মিডিয়াল অন আইদার সাইড অফ দ্য মিড লাইন যে দুটো কলাম তৈরি হবে, এইখানে একটা, এইখানে একটা, এই দুটো কি হবে বলো তো? দিস আর দ্য সোম্যাটিক এফারেন্ট কলাম। সোম্যাটিক এফারেন্ট কলাম। ল্যাটারাল টু দ্যাট এই যে কলামটা আছে, এই কলামটা হবে স্পেশাল ভিসেরাল এফারেন্ট কলাম, ব্র্যাঙ্কিওমোটর কলাম, সোম্যাটোমোটর, ব্র্যাঙ্কিওমোটর। Then this column, the third one, will be general visceral efferent column or visceromotor column, যেখানে আমরা সুপিরিয়ার স্যালিভারি নিউক্লিয়াসটাকে দেখতে পাচ্ছি, যেখানে হাই আপ ইন দ্য মিড ব্রেন আমরা এডিঞ্জার ওয়েস্টফল নিউক্লিয়াসকে দেখতে পাচ্ছি। বুঝেছো? তাহলে ইন দিস ওয়ে ডিফারেন্ট ফাংশনস আর বিং সার্ভড বাই এনি or all the cranial nerves arising from the brainstem. এই যে multiple types of fibers are accommodated within a cranial nerve that can only be explained from here. Likewise, in the alar plate, এই alar plateও আমরা mediolaterally চারটে কলাম will be laid down from medial to lateral. আমরা এরকম চারটে কলাম দেখতে পাবো এখানে। এইরকম একটা কলাম দেখবো, তারপর একটা এইরকম দেখবো, তারপর একটা এরকম দেখবো, আছে প্রত্যেকটার নাম থাকবে। বুঝেছো কিরকম নাম? জেনারেল ভিসেরাল অ্যাফারেন্ট, স্পেশাল ভিসেরাল অ্যাফারেন্ট, সোম্যাটিক অ্যাফারেন্ট, স্পেশাল সোম্যাটিক অ্যাফারেন্ট। চারটে কলাম ইন দ্য অ্যালার প্লেট, মিডিওল্যাটারালি জেনারেল ভিসেরাল অ্যাফারেন্ট, স্পেশাল ভিসেরাল অ্যাফারেন্ট, সোম্যাটিক অ্যাফারেন্ট, স্পেশাল সোম্যাটিক অ্যাফারেন্ট। স্পেশাল সোম্যাটিক অ্যাফারেন্ট একটা ক্রেনিয়াল নার্ভ আছে, আমরা আগের দিন বলেছি, 8 নার্ভ, ভেস্টিবুলো কক্লিয়ার। বুঝেছো? তাহলে দেখো, টু বিগিন উইথ এরকম লংগিটিউডিনাল কলামস ছিল থ্রু আউট দ্য লেংথ অফ দ্য ব্রেন স্টেম। পরে আমরা দেখছি কলামস, এই যে লং লং যে কলামস গুলো আছে, এগুলোকে মিস্ত্রি ভেঙে দিল। ভেঙে দিয়ে এই যে কলামটা, এই কলামটাকে শুধু রেখে দিল পন্টোমেডালারি জাংশন টু রিপ্রেজেন্ট দ্য 8 নার্ভ। উপরের দিক নিচের দিকের দরকার নেই, ফেলে দাও। দিস ইজ কল্ড প্রোগ্রাম অ্যাপোপ্টোসিস। প্রোগ্রাম অ্যাপোপ্টোসিস ডিউরিং গ্রোথ অ্যান্ড ডেভেলপমেন্ট আমি তৈরি করব, আবার ভেঙে দেব। বুঝেছো? ইনিশিয়ালি সহজভাবে তৈরি করতে হবে, একটা বড় কলাম তৈরি করে দিলাম, তারপর কলামের যে জায়গাটা প্রয়োজন সেই জায়গাটাকে রেখে বাকি জায়গাটাকে আমি সরিয়ে দিলাম, কারণ সেখানে তো অন্য জিনিসকে আমাকে অ্যাকোমোডেট করতে হবে। তাহলে ইন দিস ওয়ে ডিফারেন্ট ক্রেনিয়াল নার্ভ নিউক্লিয়াই আর বিং ডিসপোজড উইদিন দ্য ব্রেইন স্টেম। ঠিক আছে, বাস এইটা হচ্ছে একেবারে বেসিক ফান্ডামেন্টাল কথা। তোমাকে কি মনে রাখতে হবে? বেসাল প্লেট is for the motor neurons, alar plate is for the sensory neurons. Basal plate lies on either side of the midline, alar plates dorsolateral. Alar plates is the home for the different classes of sensory neurons. Basal plate is the home for different classes of motor neurons. Motor neurons are organized in 3 columns. Sensory neurons are organized in 4 columns. বাস হয়ে গেল। তাহলে দেখো এইটা জানলে তোমার স্পেশাল ভিসেরাল এফারেন্ট, জেনারেল ভিসেরাল এফারেন্ট কোনো অসুবিধা নেই মনে রাখা। আচ্ছা, লেট আস নাও বিগিন উইথ দ্য 9th নার্ভ। এই বেসিক জিনিসটা জানতে হবে, কারণ এইগুলোর থেকেই নেক্সটে আসবে, নেক্সট পরীক্ষায়। আমরা জিজ্ঞেস করি, ফার্স্ট টেকনিকেও জিজ্ঞেস করবো না, এরকম ব্যাপার নেই। 9th নার্ভ, ninth cranial nerve, you all know the name, glossopharyngeal nerve. 9th cranial nerve, glossopharyngeal nerve. For the glossopharyngeal nerve, what are the nuclei? ঠিক আছে, কি কি নিউক্লিয়াস আছে? For the glossopharyngeal nerve, we will find a nucleus unique to it, which is unique to the glossopharyngeal nerve. কোথায় দেখতে পাবো? In the uppermost medulla. And that nucleus is a motor nucleus. Very small, একটা motor nucleus আমরা দেখতে পাবো। That motor nucleus is being called as the inferior salivary nucleus. Inferior salivary nucleus. Inferior salivary nucleus কোথায় আছে? In the uppermost part of medulla, just below the superior salivary nucleus. ওটা আছে একেবারে lowermost pons এ, এটা আছে uppermost medulla, inferior salivary nucleus. কিরকম নিউক্লিয়াস এটা? এটা visceromotor or parasympathetic, visceromotor। আর কি? এটাকে আমরা বলবো জেনারেল ভিসেরাল এফারেন্ট। তাহলে these parasympathetic fibers will be traveling preganglionic neurons, parasympathetic bolchi, preganglionic neurons from this nucleus will be traveling via the glossopharyngeal, will leave the glossopharyngeal via its one of the branches. এই ব্রাঞ্চটার নাম মনে রাখতে হবে। This branch will be carrying sensory fibers as well as parasympathetic fibers. তাহলে these visceromotor or parasympathetic fibers will be leaving the 9th nerve as one of its branch. What is the name of this branch? Tympanic branch. Tympanic branch. Sensory as well as parasympathetic fibers. Parasympathetic fibers. Sympathetic as well as, sorry, sensory as well as motor fibers. Motor fibers, visceromotor. ঠিক আছে? কেন tympanic branch বলছি? Very easy, because it will reach the tympanic mucosa, মানে middle ear cavity. Tympanic cavity মানে middle ear cavity. Middle ear cavity যে mucosa সেখানে পৌঁছে যাবে। পৌঁছে গিয়ে this will be giving rise to a plexus in the medial wall of the tympanic cavity. প্লেক্সাসটার নাম কি? tympanic plexus. সব ইম্পর্টেন্ট পরীক্ষার জন্য। tympanic plexus. Tympanic plexus of nerves underneath the mucosa in the medial wall of the middle ear cavity. From this tympanic plexus, a nerve will issue. এখান থেকে আবার একটা নার্ভ বেরোবে, নাম পাল্টে যাবে। আর সেটাকে tympanic branch বলতে পারবো না, কারণ in the tympanic plexus exchange of fibers হয়েছে between different nerves, plexus তৈরি হয়েছে তো। কাজে এখান থেকে যে নার্ভটা বেরোবে from the tympanic plexus, it will be called as the lesser superficial petrosal nerve. Lesser superficial petrosal in the tympanic cavity, in the medial wall. It will leave the petrous temporal. It will leave the petrous temporal in the base of skull. ঠিক আছে? Very much inside the base. Cranial base থাকবে. Middle cranial fossa. Anterior surface of petrous temporal. Then it will leave the cranial base through either the foramen ovale or a foramen for this nerve. এই নার্ভটার জন্যই একটা ফোরামেন পেতে পারি ফোরামেন ওভেলের বাইরে। কি নাম? ক্যানালিকুলাস ইনোমিনেটাস। তাহলে লেসার সুপারফিশিয়াল পেট্রোসাল নার্ভ ক্রেনিয়াল ক্যাভিটি থেকে কিভাবে বের হয়ে পরীক্ষায় জিজ্ঞেস করতে পারে, এগুলো সব ইম্পর্টেন্ট, শর্ট নোটে আসতে পারে। ফোরামেন ওভেল দিয়ে বেরোয় অথবা ক্যানালিকুলাস ইনোমিনেটাস দিয়ে বেরোবে, লেসার সুপারফিশিয়াল পেট্রোসাল নার্ভ। Then these fibers, these parasympathetic fibers are important because we are telling about the visceromotor nucleus or the general visceral efferent nucleus. These fibers will leave the cranial base via either of these foramina and will be relaying in a cranial parasympathetic ganglion. Ki naam? Otic ganglion. In the otic ganglion there will be post-ganglionic neurons. তাহলে এই লেসার সুপারফিশিয়াল পেট্রোসাল নার্ভ প্যারাসিম্প্যাথেটিক ফাইবার ganglion in the infratemporal fossa, in the infratemporal fossa এই রকম গ্যাংলিয়ন আছে। এই গ্যাংলিয়নের ভেতরে এই সব সেল বডি বসে আছে, এই সেল বডি বসে আছে, সেল বডি। এই সেল বডিতে লেসার সুপারফিশিয়াল পেট্রোসাল নার্ভের ফাইবাররা এসে রিলে করছে, রিলে করছে, রিলে করছে, রিলে করছে, রিলে করছে, রিলে করছে। এবার these neurons, postganglionic neurons will be sending their axons, will be sending their axons, axons. These are the axons. These axons will collect. Where? These axons will be collecting and traveling via which nerve? Auriculotemporal nerve, a very important branch from the posterior division of the mandible. Most of the fibers are sensory, but some fibers are parasympathetic, and such fibers will be reaching where? Via the parotid branches, the parotid gland. তাহলে এই যে নার্ভ, এইটার নাম কি? এটার নাম এই যে এটার নাম অরিকুলোটেম্পোরাল নার্ভ। কোথায় যাবে? ভিসেরোমোটর ফাইবারগুলো প্যারোটিড ব্রাঞ্চেস, প্যারোটিড ব্রাঞ্চেস টু দ্য প্যারোটিড গ্ল্যান্ড, টু দ্য প্যারোটিড গ্ল্যান্ড। এটা ইএনটি যারা ফাইনাল পরীক্ষা দেবে, ইএনটি যারা ফাইনাল পরীক্ষা দেয়, ইএনটি এমএস, তাদের জিজ্ঞেস করা হয়। ফার্স্ট এমবি যারা পরীক্ষা দেবে তাদেরও জিজ্ঞেস করা হতে পারে ইন বিটস এন্ড পিসেস। তোমাকে আমি পুরো ট্রেস করতে বলবো না, ঠিক আছে, কিন্তু আমি জিজ্ঞেস করব। Parotid gland is a salivary gland. Secretomotor supply is derived from which nerve? Auriculotemporal nerve. It is a branch of posterior division of mandibular. Posterior division of mandibular, essentially it is a sensory nerve, sir. Then how can it carry parasympathetic motor fibers? Sir, these fibers are derived from the otic ganglion. Which nerve will carry parasympathetic motor fibers to the otic ganglion? Lesser superficial petrosal nerve, sir. Where from it is derived? Tympanic plexus, sir. Which nerve is carrying fibers to the tympanic plexus? Tympanic branch of glossopharyngeal nerve, sir. করতে করতে inferior salivary nucleus. বলে দেয়, not all students are like you people. ক্লাসের বিগিনিং এ ওয়াশরুম যাচ্ছে, এইরকম ফার্স্ট এমবি পরীক্ষায় বলে দিয়েছে আমাকে। মানে আমি 30 বছর পড়ে যা শিখেছি 1 বছরে হজম করে ফেলেছি। এরকম ব্রিলিয়ান্ট ছেলে মেয়ে আমি দেখেছি, বুঝেছো? আর তোমরা কি কিছুই করছো না, ইউ আর ফর সেলিব্রেশন। nothing is there in celebration. In celebrating every event, what you are doing? You are guided by the West and you have borrowed concept from the West. You are promoting the market. You are helping market economy. তুমি বলবে স্যার মার্কেট ইকোনমি ছাড়া স্যার গ্রোথ কি করে হবে? হ্যাঁ, এ তো গ্রোথকে হেল্প করছে, আই অ্যাডমিট, বাট ডোন্ট গো অলওয়েজ ফর মার্কেট ইকোনমি। বেসিকেও যাও বাবা, শুধু সেলিব্রেশনেই সবকিছু নেই। সেলিব্রেট করছে, আচ্ছা, তাহলে ইনফিরিয়ার সেলিব্রারি নিউক্লিয়াস, 9th নাম। নেক্সট, নিউক্লিয়াস, ডিসক্রিট নিউক্লিয়াস, ঠিক আছে। ফাইবার্স আর লিভিং only via the glossopharyngeum. Unique nucleus for the glossopharyngeum. The next nucleus, এই নিউক্লিয়াসটা কিন্তু একটা নিউক্লিয়াস, নাম আমি অলরেডি বলেছি। It belongs to other cranial nerves as well. কি নাম? Solitary nucleus or nucleus of tractus solitarius. Nucleus of tractus solitarius. Nucleus of tractus solitarius. Forte NTS. Nucleus of tractus solitarius. এই নিউক্লিয়াসটা কোথায় পাবো? ইন দ্য আপার মেডালা। মেডালার তো বেশ ভালো লেংথ আছে। মেডালার পুরো নাম বলো? মেডালা ওবলঙ্গাটা। কেন নাম? ওয়াই দ্যাট সাফিক্স ইজ দেয়ার। মেডালাটাকে, ব্রেনের যে অংশ মেডালা, তাকে স্পেসিফাই করার জন্য ওবলঙ্গাটা কথাটা কেন বলা হয়েছে বলো? হ্যাঁ, ওবলং। ওবলং মানে কি? What is meant by oblong? This is a সন্ধি. This is a সন্ধি of obliquely long. Obliquely long. তাকে সন্ধি করে ওবলং শব্দটা এসছে, বুঝেছো? মেডালাটা দেখতে কিরকম? যখন থাকে অ্যানাটমিক্যাল পজিশনে, মেডালা উইল বি লাইক দিস। মেডালা উইল বি লাইক দিস। This is medulla. From here issue the spinal cord and here lies the pons. তাহলে this is medulla oblongata. This is how it is in anatomical position in the crevice of the base of skull, and it reaches the foramen magnum, comes out. সেই জন্য এটার নাম হচ্ছে medulla oblongata, বুঝেছো? তাহলে in this medulla oblongata we will be finding this nucleus. This nucleus will be like this. এটা একটা লং নিউক্লিয়াস, এইরকম মতো একটা লং নিউক্লিয়াস আমি দেখতে পাবো, লং একটা নিউক্লিয়াস, elongated column, and overlying this nucleus we will be finding a tract of nerve fibers overlying this nucleus. এর উপরে নার্ভ ফাইবার থাকবে, তার নাম solitary tract. Such nerves will be relaying in the neurons of that nucleus. বুঝেছো? এই যে লম্বা একটা নিউক্লিয়াস দেখছি, এর গায়ে পড়ে থাকবে একটা ট্র্যাক্ট made up of nerve fibers belonging to so many cranial nerves. They will be relaying in the nucleus, carrying sense of taste. Carrying sense of taste. তার মানে স্পেশাল ভিসেরাল অ্যাফারেন্ট। ঠিক আছে, এইবার দেখো এই যে নিউক্লিয়াস, এই নিউক্লিয়াসটার এখানে যে নিউরনগুলো আছে, এখানে যে নিউরনগুলো আছে, এখানে আর এখানে, এটা হচ্ছে 7th নার্ভ, 7th, এটা 9th, এটা 9th, এটা 10th, 10th। তাহলে a single nucleus which goes by the name of NTS serves 3 cranial nerves, 7th, 9th, 10th. Why? The answer is this nucleus, its cranial half. দেখো আমি একটা অংশ রেখে দিয়েছি, এই নিউক্লিয়াসের আরেকটা অংশ আছে, এখানে আরেকটা অংশ আছে, সেটাকে আমি রেখেই দিয়েছি, এই অংশ। its cranial part is concerned with taste. Taste, তাহলে ফাংশনটা তো একই, স্পেশাল ভিসেরাল অ্যাফারেন্ট, কাজে একই রকম নিউরনস। But taste fibers for the tongue are carried by chorda tympani, a branch of 7, posterior third, glossopharyngeal, vallicula near the root of the tongue, internal laryngeal, branch of vagus. তাহলে তিনটে ক্রেনিয়াল নার্ভকে দিয়েছি টু সাপ্লাই টেস্ট ফাইবার্স টু দ্য টাং। তার কারণ টাং ইজ দ্য only organ available in the human body for perceiving the sense of taste. Therefore, so many cranial nerves are assigned for the task. একটা যদি চলে যায় আর একটা তো রইল ভাই, বুঝেছো? সেই জন্য দেখো নেচার কত প্রুডেন্ট ইন হিজ অর্গানাইজেশন। একটা ক্রেনিয়াল নার্ভ দেয়নি, তাহলে ওটা যদি চলে যায় বিরিয়ানি, ঠিক আছে, বিরিয়ানির টেস্ট রসগোল্লার মতো লাগবে, টেস্টলেস, এভরিথিং ইজ টেস্টলেস, নাথিং ইজ দেয়ার। সেই জন্য তিনটে ক্রেনিয়াল নার্ভ দিয়েছে। বাট দ্য নিউরনস, ঠিক আছে, দ্য নিউরনস আর দেয়ার ইন দ্য সলিটারি নিউক্লিয়াস। হলো? তাহলে আর একটা নিউক্লিয়াস আমরা পেলাম, এনটিএস। তাহলে এনটিএসটা কিরকম নিউক্লিয়াস? স্পেশাল সেন্স অফ টেস্টকে সার্ভ করছে, কাজে স্পেশাল ভিসেরাল অ্যাফারেন্ট, স্পেশাল ভিসেরাল অ্যাফারেন্ট, ঠিক আছে। নেক্সট আর কি নিউক্লিয়াস আছে? এর glossopharyngeal nerve carries general sense from the posterior third of the tongue. You have read general sense and the sense of taste, তাই তো? glossopharyngeal nerve carries the sense of taste from the posterior pharyngeal wall as well. Gag reflex, gag reflex, glossopharyngeal নার্ভটা হচ্ছে সেন্সরি কম্পোনেন্ট। তাহলে posterior pharyngeal wall mucosa is innervated by glossopharyngeal. Such fibers are for general sensation. তাহলে there must be a nucleus, a set of neurons to serve the general sense. টাঙের posterior third-এ আমি যদি আঙুল দিয়ে চাপি, that is not taste, that is touch. To carry the sense of touch to the brain stem, glossopharyngeal fibers are there. There must be a separate set of neurons. Where they are? It is easy. They are in the caudal part of the solitary nucleus. সহজ হয়ে গেল, একই নিউক্লিয়াস, এর যে কডাল পার্ট, এই কডাল পার্টে আছে, এই কডাল পার্টে জেনারেল সেন্সের জন্য নিউরনস আছে। কডাল পার্ট, এই কডাল পার্ট, কডাল পার্ট ফর জেনারেল সেন্স, এই কডাল পার্ট is for general sense. This is for general visceral sense. General visceral sense. General visceral sense. তাহলে জেনারেল ভিসেরাল সেন্স মানে glossopharyngeal nerve, তাহলে solitary nucleus. Again, this nucleus, caudal part is for general visceral afferent. General visceral afferent, caudal part of the solitary nucleus. তাহলে দেখো একটা নাইন্থ নার্ভ, যেটাকে মনে হয় সিমিংলি, তুমি তো ডিসেকশনে দেখোনি, টাং যখন পড়েছো জায়গায় জায়গায় স্যারেরা বলেছেন, অনুজিৎ স্যার পড়িয়েছে, তুমি ভাবলে ওটার কোনো ইম্পর্টেন্স নেই। ইম্পর্টেন্স আছে। সো মেনি নিউক্লিয়াই আর দেয়ার ইন দ্য মেডালারি পার্ট অফ দ্য ব্রেন স্টেম। এখানেই কি শেষ? নো, এখনো কনক্লুড করা গেল না। নাইন্থ নার্ভ has got another nucleus which also belongs to the 10th, which also belongs to the 11th. That nucleus is a round or spherical nucleus. We find it deep within the medullary substance in its upper part. What is its name? Name is nucleus ambiguous. Nucleus ambiguous. তাহলে আমরা আরেকটা নিউক্লিয়াস 1, 2, 3, এটা 3, 4, nucleus ambiguous. Nucleus ambiguous. Ambiguous. What type of nucleus it is? It is special, visceral, efferent, meaning branchiomotor. Branchiomotor. তাহলে glossopharyngeal nerve carries visceromotor fibers, carries fibers of special sense taste, fibers of general sense, and also branchiomotor fibers. To supply a single muscle, for that single muscle, a group of neurons will be there in the nucleus ambiguous. Everybody should know the name of that muscle. তার কারণ একটাই মাসল আছে, 9th নার্ভ দিয়ে সাপ্লাইড হয়, না বলতে পারলে আউট। হেড নেকের পরীক্ষায় ফ্যারিংস জিজ্ঞেস করবো আমি, যদি বলতে না পারো তুমি, তোমাকে সঙ্গে সঙ্গে বলবো ইউ মে গো, সেইরকম নম্বর দিয়ে দেবো। তার কারণ এত ইম্পর্টেন্ট একটা ক্রেনিয়াল নার্ভ, 9th নার্ভ, একটাই মাসেলকে সাপ্লাই করে, তুমি তার নামটাও মনে রাখতে পারলে না, তা তোমার থাকার কোনো দরকার নেই। ইউ মে গো, লিভ। The name of that muscle is stylopharyngeus. Stylopharyngeus. There are 3 longitudinal muscles in the pharyngeal wall: stylopharyngeus, palatopharyngeus, salpingopharyngeus. Of the 3 longitudinal muscles, stylopharyngeus is supplied via glossopharyngeal. Fibers are branchiomotor. Where lies the nucleus? Nucleus ambiguous cell. Where you will find it? In the medulla. কিছু অসুবিধে নেই, but you have to read. At the beginning of the class, sir, washroom. In the middle of the class, sir, washroom. That means you have no interest in learning, reading or anything. You have got the only interest to roam about freely in SMC campus and celebrating all the time. And celebrating all the time. ऐसा करके नहीं चलेगा भाई, पढ़ना भी है, कुछ तो पढ़ना है। এবার একদল ছেলে আছে, দেখছে স্যার তো এইসব বলে, স্যারেরা কি দরকার, লেট আস বার্ন দ্য ক্লাস। শুনলাম ওরা বলছে উই হ্যাভ গিভেন মানি, হোয়াই শুড উই রিড? আমি তো ক্যাপিটেশন দিয়ে এসছি। উই হ্যাভ নো অব্লিগেশন টু এনিবডি। উই হ্যাভ গিভেন মানি টু মলয় বাবু। ইট ইজ দ্য ডিউটি অফ মলয় বাবু to see us passing with flair in first MB Porikha by copying. I do not know what the management people will do. They might give you the books so that you can copy. ঠিক আছে, যাই হোক, আমার কিছু করার নেই। আরে ভাই, এসব একটা সবকিছু আছে। There must be limits of everything. You may have enough money, you may buy everything, but you knowledge, বুঝেছো? Knowledge you can buy, cannot buy, and without knowledge, কি আমি তুমি কি করবে? তুমি হয়তো একজন নার্সিং হোমের মালিক টালিক হবে, এরকম ভাবছে যারা সব আসছে না ক্লাসে। They might be thinking like that. আচ্ছা, নেক্সট 10th nerve. Next 10th nerve, vagus. Very vague. Vagus is so called because it is vague. ঠিক আছে, that vagus nerve has got nucleus. ঠিক আছে, which one is the most important nucleus of vagus? একটা নিউক্লিয়াস যেটা তোমাকে বলতেই হবে, that is the dorsal motor nucleus of vagus. Dorsal motor nucleus of vagus. 10th nerve. 10th nerve, vagus. The first nucleus is dorsal motor nucleus of vagus. Dorsal motor nucleus, DMN. What type of nucleus it is? General, visceral, efferent. That means in this nucleus you will be finding all the parasympathetic fibers. All the parasympathetic fibers. ঠিক আছে, all such parasympathetic fibers of vagus will be reaching some of the organs of head and neck and so many important organs in the thorax and abdomen, carrying parasympathetic fibers. This dorsal motor nucleus of vagus, কেন তোমাকে বললাম এটা জানতে হবে? You can find this nucleus, not the nucleus, but the site of the nucleus. Nucleusটা কোথায় আছে? To represent the nucleus, there is a feature in the floor of the fourth ventricle, in the caudal part of the rhomboid fossa. একটা ছোট্ট জায়গা আছে ট্রায়াঙ্গুলার, নাম হচ্ছে ভেগাল ট্রায়াঙ্গেল। ভেগাল ট্রায়াঙ্গেল, বুঝেছো? ইন দ্য কডাল পার্ট অফ দ্য ফ্লোর অফ দ্য রম্বয়েড ফসা। রম্বয়েড ফসার কডাল পার্টের ফ্লোরটা যদি এরকম হয়, এরকম যদি হয়, এখানে আমরা একটা এরকম ট্রায়াঙ্গেল দেখব, আবার একটা এরকম ট্রায়াঙ্গেল দেখতে পেতে পারি, বুঝেছো? সরি, এটা মিড লাইন। এই মিড লাইনের কাছে এইরকম এইরকম আমরা সব ট্রায়াঙ্গেল দেখব। এটা যখন ফোর্থ ভেন্ট্রিকলের ফ্লোর পড়ানো হবে তখন বলা হবে, নাম হচ্ছে ভেগাল ট্রায়াঙ্গেল। ইন দ্য ফ্লোর অফ রম্বয়েড ফসা দেখতে পাওয়া যায় ছোট্ট একটা ট্রায়াঙ্গুলার এরিয়া, ভেগাল ট্রায়াঙ্গেল। তোমাকে জিজ্ঞেস করবে, হোয়াট ইজ ইট? ভেগাল ট্রায়াঙ্গেল স্যার, হোয়াট লাইজ বিনিথ ইট, or why it is being called as the vagal triangle? Answer is, beneath the ependymal floor of the fourth ventricle lies the dorsal motor nucleus of vagus. ঠিক আছে? dorsal motor nucleus of vagus এ কি আছে? preganglionic parasympathetic neurons serving the vagus. বাস হয়ে গেল। আচ্ছা, নেক্সট, after the dorsal motor nucleus, the next nucleus will be, the next nucleus of importance for the 10th nerve is nucleus of tractus solitarius. Of tractus solitarius. Nucleus of tractus solitarius. In this nucleus of tractus solitarius, you will find both special visceral afferent serving taste and general visceral afferent fibers, parasympathetic sensory fibers from the organs innervated by the vagus. ঠিক আছে? তাহলে নিউক্লিয়াস অফ ট্র্যাক্টাস সলিটারিয়াস সার্ভিং the sensory fibers of vagus, both special visceral sense of taste and the general visceral sense. ঠিক আছে? Next, number 3 is nucleus ambiguous. Nucleus ambiguous. Nature of this nucleus is SVE, special visceral efferent branchiomotor. That means vagus nerve has got plenty of neurons in the nucleus ambiguous, and such neurons will be supplying muscles derived from the fourth pharyngeal arch and the muscles derived from sixth pharyngeal arch. বুঝেছো? The cricothyroid and all the intrinsic muscles of larynx. ঠিক আছে? cricothyroid, all the intrinsic muscles of larynx, plus আজকাল বলা হচ্ছে যে vagus also supply the pharyngeal muscles. এখন সেই রকম বলা হচ্ছে। তা কিন্তু তোমাকে তোমার জন্য remember, all the intrinsic laryngeal muscles are supplied by the vagus. The cricothyroid, the only tensor muscle, tensor of the vocal fold, it is derived from fourth pharyngeal arch myotome, supplied by internal laryngeal nerve. বুঝেছো? A branch of superior laryngeal. Vagus supplies the muscles from the fourth arch. Vagus also supplies the muscles derived from the sixth arch. তার কারণ ভেগাসের একটা লং কোর্স আছে নেকে। বুঝেছো? নার্ভের নাম কি? ল্যারিঞ্জিয়াল নার্ভ। ইন্টারনাল, সরি আমি ইন্টারনাল বলে যদি বলে থাকি ভুল বলেছি। এক্সটার্নাল ল্যারিঞ্জিয়াল নার্ভ সাপ্লাইং দ্য ক্রিকোথাইরয়েড, রিকারেন্ট ল্যারিঞ্জিয়াল নার্ভ, রেস্ট অফ দ্য ইন্ট্রিনজিক ল্যারিঞ্জিয়াল মাসেলস। এক্সটার্নাল অ্যান্ড রিকারেন্ট, ইন্টারনাল হচ্ছে সেন্সারি। তাহলে নিউক্লিয়াস অ্যাম্বিগুয়াস হয়ে গেল, ভেগাস শেষ। আর ভেগাসের কোনো নিউক্লিয়াস নিয়ে তোমাকে জানতে হচ্ছে না, এই নিউক্লিয়াসের দুটোই আছে। আচ্ছা, নেক্সট তুমি চলে এসো 11 রিলেটিভলি ইজি, আমি বলবো না, বইয়ে ছোট্ট কথা লেখা আছে, পড়ে নিও। হাইপোগ্লসাল 12th নার্ভ, ভেরি ইজি, only only on either side of the midline serving the paired hypoglossal nerve, we will find the hypoglossal nucleus. কিন্তু অনেকটা জায়গা জুড়ে থাকবে, because it is supplying the muscles of the tongue. So important. টাঙের মাসেল ভীষণ ইম্পর্টেন্ট। এই যে আমি তোমাকে অ্যাবিউসিভ কথাবার্তা বলছি, তোমাকে পড়াচ্ছি, এভরিথিং ইজ হেল্প বাই মাই টাং। আমার জিভ, বুঝেছো, আমাকে লোকে বলে যে আপনার জিভটা ভীষণ মারাত্মক কড়া টাইপের জিভ, আপনি সবাইকে গালি দেন। হ্যাঁ, তো আই এম ইউজিং মাই জিভ, টাং। তাহলে টাঙের মাসেলকে ইউজ করা জানতে হবে, বুঝেছো? ইউজ করতে গেলে ইউ শুড হ্যাভ নলেজ, তবে তো তুমি গালি দিতে পারবে। পিপল উইল ডাইজেস্ট ইউর গালি, নো ওয়ে আউট। তো টাং মাসেলস আর ভেরি ইম্পর্টেন্ট। টাং among all its functions, it serves us in speech, ভীষণ ইম্পর্টেন্ট। সেই জন্য কাজেই হাইপোগ্লসাল নিউক্লিয়াসটা অনেকটা জায়গা জুড়ে থাকবে। কোথায় থাকবে? beneath the rhomboid fossa, beneath the hypoglossal triangle. ডেফিনিট ফিচার আছে রম্বয়েড ফসায়, তুমি দেখতে পাবে মেডালারি পার্ট অফ দ্য রম্বয়েড ফসা, মেডালার অপোজিটে যে জায়গাটা আছে ফ্লোর অফ দ্য ফোর্থ ভেন্ট্রিকল, হাইপোগ্লসাল ট্রায়াঙ্গেল আছে। তাহলে নিউক্লিয়াসটার নেচার কিরকম হবে? টাঙের মাসেলসকে সাপ্লাই করছে। কি বলবে আর তুমি একে? একে আমরা বলছি, দেখো কি মজা, দেখো মানে অদ্ভুত অদ্ভুত মজা বা গন্ডগোল আছে। এই যে হাইপোগ্লসাল নিউক্লিয়াস, টাংটাকে আমরা বলছি ডেভেলপিং ইন দ্য ফ্লোর অফ ফ্যারিংস, হুইচ ইজ ভেরি মাচ অ্যান অর্গান, ভিসেরা তো, তাই না? অথচ টাং মাসেলসকে যারা সাপ্লাই করছে, এই যে নিউক্লিয়াস, একে আমরা বলছি সোম্যাটোমোটর। সোম্যাটোমোটর, সোম্যাটিক এফারেন্ট, হাইপোগ্লসাল নিউক্লিয়াস, 12th nerve, 12th nerve, 12th nerve, নিউক্লিয়াস, হাইপোগ্লসাল, হাইপোগ্লসাল, হাইপোগ্লসাল নিউক্লিয়াস কিরকম? সোম্যাটিক এফারেন্ট কলামকে রিপ্রেজেন্ট করে। তাহলে দেখো এই যে একটা রিডল বা একটা কনফিউশন, এটা এখনো কনফিউশন রয়ে গেছে। যখনই আমি বলছি, দেখো না না সরি 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 আমি তোমাকে রিডলটা সলভ করিয়ে দিচ্ছি। Why tongue muscles are supplied from the hypoglossal nerve? Tongue is developing in the floor of pharynx. Pharynx is an organ or viscera, but the nucleus we are calling it as somatomotor. তোমাকে জিজ্ঞেস করবো হোয়াট ইজ দ্য রিজন? এই যে আমি কেন বলতো আমি কনফিউজ করলাম, ব্যাপারটা কি? আমি তো ভাই, আমিও তো মানুষ, আমি তো অ্যানাটমি পড়াচ্ছি, কত ফ্যাক্টস মনে রাখতে হয়। আর আমি তো পড়াই না, আমি কখনো বই ফই খুলছি না। ফর দ্য লাস্ট 5 years কোনো বই ফই খুলি না আমি। কাজে মাঝে মাঝে এত ফ্যাক্টস না, মাঝে মাঝে গন্ডগোল হয়ে যায়। সেই গন্ডগোলটাই হচ্ছিল, কিন্তু ঘটনাটা ব্লান্ডারটা করলাম না। যাই হোক, মানে থ্যাঙ্কস টু আই ডোন্ট বিলিভ ইন গড, কিন্তু থ্যাঙ্কস টু সামবডি আমাকে বাঁচিয়ে দিয়েছে। আচ্ছা, মাসেলস অফ দ্য টাং, মাসেলস অফ দ্য টাং আর ডিরাইভড ফ্রম সোমা। Tongue is an organ. Muscles are derived from soma. Soma মানে bodily something. Bodily something মানে somites. Occipital somites. Occipital somites এর myotome migrate to the muscles. That is why we are calling the hypoglossal nucleus as somatic efferent. বুঝেছো? দ্যাট ইজ দ্য রিজন। ইন দিস ওয়ে, ব্যাপারটা কি বলো, দেখো আমি কারেক্ট করলাম কি করে? আমি কারেক্ট করলাম, কিন্তু আমার মনে হচ্ছে কি, কেন? ইউ হ্যাভ টু আস্ক ইয়োরসেলফ। আমি যখনই বললাম দেয়ার ইজ এ রিডল, না রিডল হ্যাজ বিন সলভড, তখন আমার ব্রেন বলছে না দেয়ার ইজ নাথিং, রিডল হ্যাজ বিন সলভড, বিকজ tongue muscles are derived from occipital somites, occipital myotome. That is why it is being supplied by the hypoglossal. Barring one, palatoglossus টাকে সাপ্লাই করে না, বাকি সব tongue muscles, extrinsic, intrinsic, are supplied from the hypoglossal nerve. That completes our discussion about the cranial nerve nuclei. Tomorrow, I will be discussing about the 7th cranial nerve, which is very important. ঠিক আছে, কালকে আমরা ওইটা ক্লাস নেব।
Or localized inflammation and putrefaction or give rise to a destruction of this lung tissue and produce lung abscess. What is the cause? The cause may be a primary or it may be a secondary. When it is come in the primary as a normal lung tissue, without any injury or without any lesion in the lung, they produce a lung abscess. Or secondary, when that lesion is come from the outside or associated with the lung or from the source from the other side of the body, they produce the secondary lung abscess. Source, then how the organism or the infection comes. It may be a aspiration, that is the organism come through the aspiration, whatever may be the source the organism or the notorious organism, gram-negative, there's nocardia, then there is a Klebsiella, these are the organism. And how this type of patients are victim? Usually at unconscious, semi-conscious, alcoholic patients, or they have the less cardio, that is the cough reflex is less, so they are very often they are aspirated this material of infection and produce the aspirated pneumonia and lung abscess. Or it may be a septic emboli. Anywhere, this is septic emboli anywhere in the body, maybe in the lung, maybe in the other side of the body, they are come as a septic focus from the circulation, they produce these things. From the cardiac vegetation, these are the septic focus. Then aspirations of that thing are the obstruction. Sometimes that obstructive lesion in the bronchus, maybe a neoplastic lesion or carcinoma bronchus or a metastatic lesion, they obstruct the bronchus. So the outlet passes of this infected material, they are jeopardized. So they are stagnant and produce the obstructing of the airway passes and produce the infection and pneumonia or lung abscess. Or it may be other cause from the trauma. Road traffic accident may give rise to that trauma, or the trauma to the spine and that produce the infection and go to the lungs properly and give rise to this thing, and the septic emboli, they circulate through the subsystem circulation and lodge in the lungs and produce the infection. Now the pathogenesis, how these are causes this lung abscess. So I told this is aspiration. Aspiration coming from the food material, maybe upper GI, maybe the oral cavity, the oral periodontal infection or denture, or it may be from the upper respiratory tract, or it may be from an endobronchial tube, tracheostomy tube, they give rise to a septic focus and give rise to that aspiration. And what are the patients are victim? They are usually comatose patient, unconscious patient, or alcoholic patient. They don't have any proper consciousness or depressed cough reflex, so they will not cough out that thing. So that produce the aspiration pneumonia and that lung abscess. Then that is the bronchial infection. Complication of the, I told this is local pneumonia, bronchial pneumonia as a complication, they produce the infection and not removed properly, they produce the lung abscess. Next one, the other causes of the infection. Maybe local pneumonia, bronchial told, other infection, chronic infection as a tuberculosis, maybe fungal infection, maybe a parasitic infection, maybe a coming from the side, other surrounding tissue, they produce these things. Already you know that parasite, that is the hydatid cyst, the amoebiasis, they also come from the other sides, they produce this infection. Then bronchial obstruction I told, any enlarged lymph node, mediastinal mass or any tumor or metastatic tumor, they obstruct the surrounding bronchus and give rise to a abscess formation. Then septicemia, that also very important. Septicemia are anywhere in the body. They go to the systemic circulation, go to the directly from the system to the right side of the heart, and from the heart they go to the lung. And they lodge in the lung, produce a micro abscess formation and coalesce to form a few millimeter to few centimeter lung abscess. and others are extension from the surrounding tissue, that is amoebic liver abscess, subphrenic abscess, subdiabetic abscess. They go directly from the as a complication lodge in the lung, and this thing they produce. So these are the sources of infection from where we got that infection. If not removed, if not cured by antibiotic, they will give rise to a severe septicemia, severe shock, and patient will die with this organism and infection. And also there is some road traffic accident and immunocompromised patient, immunotherapy, patient also depressed this immunity, so they are not remove these thing organism and produce this. Now what is this happen? The lung, the septic focus, whatever may be the source, they lodge in the lung, produce a small consolidation, that thing, the micro abscess. Then this micro abscess, some of this coalesce to form a macro abscess, that is the extend from the few millimeter to few centimeter as a macro septic formation and this abscess formation. If that not removed by the antibiotic, they produce the lung abscess. Naturally, usually with good immunity, patient will recover in very quickly and with antibiotic. But previously it was not that, so patient will die with the absence of the antibiotic or proper antibiotic. But nowadays the patient got the proper antibiotic, clinician also help to survive the patient things. But immunocompromised patient with the immunocompromised drugs, they are very much jeopardized and produce the septic shock and patient death. So this is the outcome of these things. So delayed treatment, inadequate treatment, patient undergoes the septicemia and shock. Now infection, what happened? When they lodge, they destroy the lung tissue, they produce the microabscess formation, and there is a they try to localize these things and surrounded by the pyogenic membrane and a septic focus surrounded by the chronic case, surrounded by the fibrous fibrocollagenous wall. So this is the pathogenesis. So this thing, aspiration, the material or the foreign body produce pneumonitis. What happened? These pneumonitis, they are unable to cough out or aspirate material, this thing. And if this collected, the blood vessels supplied on that focus area, they also jeopardize. So no blood supply, no food material. So that area, central area undergo necrosis and abscess formation. And this established pathogenesis produce the lung abscess. Now what are the risk factor of this case? Risk factor, what are those patients are sufferer? The risk factor, you know already, that is the immunocompromised patient or the alcoholic patient associated with the disease of the lung. They are hampers of these things. That is the comatose patient, drug abuse, general anesthesia, have convulsive disorder. They are aspirate that thing very quickly. Then these are oral hygiene. Some patients have poor dental hygiene, some artificial denture, or patient have artificial tracheostomy. They are produce the harbor of the organism and this infection will go there. So these are the some risk factor. So others are the upper respiratory tract infection that I told. They are aspirated from the stomach material, vomitus, frequent aspirated from the upper GI or upper respiratory tract. They also lost the infection in that way. Then other conditions are the metabolic disorder, that is very often is a diabetes. They are also a poor patient. They have some difficulty in the cuff reflex or neuromuscular difficulties they also have. They produce this cuff reflex difficulty and lost the infection that way. And alcoholic patient, their level of consciousness are different. They also aspirate any time, any food particles or anything. They are the risk factor. Now, what is the morphology then? So, the examiner, they will ask what is the definition, what is the lung abscess, what are the organism or what are the source of infection, what is the pathogenesis, means morphology, that is the gross examination and microscopic examination. Gross examination, what is this thing? This is the lung. See this small focus, that is a micro abscess. they coalesce to as a big abscess, they produce a cavity formation like this. So filled with the ragated margin, that the wall is ragated. So it's a microabscess, macroabscess and the cavity formation. And it is progress to progress, give rise to a chronic lung abscess. So this is a big cavity. This is a lung, this is the trachea, bronchus, this is the multiple abscess formation as a cavity. These are the multiple abscess formation, that the cavity formation. So these are some gross examination of these things. The lung is congested, microabscess formation, macroabscess formation and a cavity formation. Now, what side of the lung is affected? Usually, right side of the lung, upper apical lobe is the right side is very much affected. Why it is affected? This is acutely, right bronchus is acutely goes to the right side. That's why the apical part of the right lung is affected. And the apical part of the both lower lobe also a source of lodge. And if it is an alcoholic patient or supine position or in the bedridden patient, their posterior part of the right lobe also affected. So what is this thing? Which side of the lung is affected? You will tell that is the right side of the upper apical part of the right side. If it is a supine or bedridden patient, posterior part of the right side of the lung is affected. Now microscopy. See this. This is the abscess formation. This is centrally. That is the exudate. The exudate is centrally placed, and this is a pyogenic membrane. This is localized by this pyogenic membrane. Small abscess coalesced to form a big thing and is infiltrated by the neutrophil. And chronic lung abscess, this contains, including the neutrophil along with the lymphocyte, plasma cell, macrophages, they produce a chronic lung abscess and lined by a pyogenic membrane. If goes to continue chronic case, they are lined by fibrocollagenous tissue as the localized form. So this is the microscopy. So small microabscess to large macroabscess containing the neutrophil in acute condition. If it is a chronic one, they produce the lymphocyte, plasma cell, macrophages, sometimes get the organism also. So lined by the fibrocollagenous tissue, then it is a chronic one. See this? This is the abscess, this is the bacteria. Acute lung abscess is composed with the plenty of the neutrophil with this exudate. So acute lung abscess full of inflammatory exudate, mostly in the neutrophil, and the center is the bacterial colony. You can easily identify the bacterial colony if it is not possible for us, but nowadays in autopsy lungs are not coming due to this antibiotic. But previously, variable we can get that autopsy material with this acute lung abscess patient after death and autopsy. And when see the center of this thing, this is the necrotic material surrounded by the pyogenic membrane and the inflammatory exudate surrounding this pyogenic membrane, this abscess formation. So this is the microscopy. Acute condition, you get the acute inflammatory cell, and it is a chronic inflammatory cell. In the chronic cases, lined by the pyogenic membrane, and more chronic lined by the fibrocollagenous tissue. Now, what I told, other than bacterial infection, we can get the fungal infection, we can get the parasite like, see, this is the hydatid cyst. Everybody have know that is from dog, we are getting the hydatid cyst. Lung also one of that lodge that can get in the liver, maybe in the lung, maybe in the kidney, and the hydatid cyst, the source from that dog, we can lodge or produce a hydatid cyst in that area, and that also produce a lung abscess. One more important thing is, this is the amoebic lung abscess. From where it get? Intestinal amoebiasis, that you have already learned. From the intestine, through the portal vein, they go to the liver abscess. As a complication of the liver abscess, they go to the lung and produce the amoebic lung abscess. See this? This is the cyst, amoebic cyst. So you can get the liver, you can get the encomious pus, and the organism get to the wall of that liver abscess, amoebic liver abscess. And from there, If it is blast or it is got a complication, join to the other side produces the liver lung abscess from the liver disease. So these are the some source of infection. Now clinical, how is manifested? Is a patient presented with the cough, dyspnea, chest pain, high fever. If it is a very late case, you can get the septic shock. So patient with this thing is complicated. The patient may present with the hemoptysis. That is the coughing out of blood. You know what is hematemesis and what is hemoptysis, that you know. Coughing out of the stomach, it is a hemoptysis, hematemesis. That is the coffee ground is color due to acid hematine formation. This is a coffee ground in color, that is a hematemesis. But hemoptysis is a fresh blood. So it is a coming out of fresh blood is called hemoptysis. Patient will tell it is a coming out of blood. But from the color you can really identify and appreciate that is the what is the difference between a hemoptysis and what is the difference between hematemesis. So patient presented with this is, and long case I presented with a clubbing, finger clubbing. See the sign of the patient. So early sign, fever, night sweat and persistent cough or prolonged period. Or if it's a patient presented with the late one, they produce the breathing difficulties, maybe in the hemoptysis or maybe when the septic shock produce a fatigue. So according to the severity of the organism and source of infection, patient presented with the different stage at different presentation due to the severity and duration of that patient. Clinical examination, when you go to the clinic, you can easily identify the patient dyspnea, tachycardia, chest pain, then hemoptysis. According to the stage of this disease, patient presented with this thing, and if you auscult that patient, that is the no bass sound, the dullness due to the abscess formation, the auscultation, this is dullness of that patient you can get. And after that, if you examine the patient, you can get that history. If you examine the patient, you can easily appreciate that patient is suffering from the lung abscess. And investigation you do, image examination, that is the physical examination, chest X-ray, you can get sputum examination, sputum culture or image analysis or the X-ray is a very important thing. And immunological test, if you know the immunological test, any immunocompromised patient, you can easily appreciate that thing. And that CT scan also very important, radiologically important, the source of infection, if it is indicated, it can aspirate the thing also for saving of that patient. Test X-ray. See, this is the abscess. Here is the horizontal line. Here is the horizontal line. This is the fluid, this is the air. So, this is a cavity filled up with fluid and air. So, when you get in abscess formation in that thing, see this thing, this is the abscess cavity, fluid is down with the horizontal line, and as it is a fluid and is a gas. This is the fluid and gas level. So, horizontal line you have read the image, you can easily identify this thing. So, examination of the patient and diagnosis confirmed. So, you can aspirate the infected material or conservative treatment, you can treat the patient. Now, what will be the complication of this case? Very important, patient may recover by proper antibiotic. If not recover, they give rise to different types of complication, and patient may die due to aseptic shock due to this complication. What is this complication? Is a empyema. That pus may engulf is entered within the pleural cavity. So pus is in the pleural cavity, that is the visceral pleura and the parietal pleura. If it is lost, they produce empyema. Sometimes it comes to the bronchopneumonia, that is the bronchopleural fistula. That the infected material from the bronchus go to the pleural cavity called the bronchopleural fistula. Then this produces it is go to the whole lung, may produce the gangrene of the lung, or it may produce, if blood vessels are eroded on that bronchial wall, they produce hemoptysis. From where it comes the blood? So eroded blood vessels in that wall of that lung or the bronchus. So it easily the blood will come out as hemoptysis. So produce hemoptysis. Next, the septic emboli. These septic emboli through blood vessels go to the different parts of the body. Most important thing is to go to the brain and produce the cerebral abscess and stroke of that thing. So these are the some complications. Other complications are the very rarely it produces the amyloidosis. You know the chronic inflammation they produce as complication as amyloidosis. So complication, empyema, bronchopneumonia, hemoptysis, septic focus from the lung to the any other part of the body, or in a long cases it produce amyloidosis. So these are the sub complications. Now, what is the prognosis of this case? If it is diagnosed early, in the early stage of the disease, patient may recover very quickly with antibiotic. That's 100%, 90%, 100% patient recover. But if not recovered, if any secondary disease associated in the lung, this may give rise to a 90% mortality of this case. So, the lung abscess, you have to know what is lung abscess, what are the source of infection, what is the pathogenesis of this thing, what is the complication of these things, what is the macroscopy, what are the microscopy, and the complication of this thing. So this is a very small topics. Maybe in the short note you can get, but as a clinician, we will go to the place, very important thing to diagnose this case. So okay. Now anything you can ask? ठीक है sir? अच्छा, you already asked to HOD madam that you know some definition. You arrange class and ask her. She will take or write the definition according to your oral or theory purpose. So previously some definitions what we are on your stage, one type of definition. Now it is simplified in a new book. So very difficult to assimilate for you. But that examiner who will come, they will ask that ancient definition. So very difficult for you. Whatever you learn, madam will help and you explain the examiner what you have learned. Okay?
In the antimicrobial agents, not only the antibiotics or antibacterial agents, there are also other agents like antiviral, antifungal, anti-helminthic, antiprotozoal, etc. So we will start with first the antibacterial agents, mainly antimicrobial. Within this, we will today cover the sulfonamides and the broad spectrum antibiotics. Two short ones. So first coming to the sulfonamides. So sulfonamide is basically the first effective chemotherapy agent. So before coming to the penicillins, the sulfonamides came, and they are employed systemically for the prevention as well as treatment of bacterial infections. So when some infections happen, we have to kill the bacteria that is causing the infection. For this, the antimicrobial agents came, and one of the first antimicrobial agents is the sulfonamide. So the term sulfonamide is basically employed as a generic name to derivatives of the para-aminobenzene sulfonamides. Para-aminobenzene sulfonamides is totally also known as sulfanilamide. So there are various derivatives of the para-aminobenzene sulfonamides. They are together called the sulfonamides. They basically contain the sulfonamide ring, SO2NH2. You can see this is the SO2NH2. So this is the ring is present commonly to all the antibacterial agents that are known as the sulfonamides. Structurally and chemically, they are related to para-aminobenzoic acid. This para-aminobenzoic acid or PABA is an important constituent for the bacterial metabolism. There are some structurally similar drugs also, like thiazides, acetazolamide, dapsone, sulfonylurea also. So these are different other agents. For example, thiazides is diabetic, you already know. Acetazolamide is diabetic. Dapsone, you will later read, it can be used as an antidiuretic agent, sulfonylurea is antidiabetic. So all these drugs usually have some derivatives of this sulfonamide. So SO2NH. Physically they are available as white powder, mildly acidic and water soluble salt. So basically they are first invented as dyes for coloring the clothes. And they have antibacterial properties. It has been seen in 1920. Domac, Gerard Domac won Nobel Prize in 1939 for the invention of a derivative of sulfonamides known as the prontosil red. Prontosil red is basically a dyeing agent for the dye of the different clothes, and it has been invented by him that it is effective in different types of the streptococcal infections. The streptococcal impetigo, that is the skin infections or throat infections, are quite prevalent in those times, and it has been seen that if they are given this dye, this infection is treated well. So Domac, Gerard Domac in 1932, first commercially available antibiotics from prontosil red was invented by him, and for this in 1939 he won the Nobel Prize. In 1937, already in 1937, the prontosil were broken down to different derivatives of the sulfonamide. So different other agents are formed. So this is the prontosil red. You can see this SO2NH2D is common, this sulfonamide ring, and these are the para-aminobenzene sulfonamide or sulfanilamide. So these are the basically main derivative agent that was invented from the prontosil red by Domac. So these are the classification of the sulfonamides. Mostly it can be classified according to their duration of action. So either it has been short acting. Examples are the sulfadiazine, sulfadiazine, and sulfocetamide. So these are the short acting sulfonamides. There are intermediate acting sulfonamides like sulfamethoxazole. Long acting sulfonamides are there like sulfamethoxypyrazine, sulfadoxine, and sulfadimethoxy. So basically these are different derivatives by changing the groups in the sulfonamide ring. There are some special purpose sulfonamides, that is, it can be given as topical agent like mefenite, silver, sulfadiazine, and sulfocetamide. Topical agent like a cream or ointment, it can be given. And for the ulcerative colitis, this is an inflammatory bowel disease, and here the sulfasalazine, another derivative of the sulfonamides, can be used. That is, from this you can see that sulfonamides not only can be used as an antimicrobial agent, it can be used in inflammatory bowel disease like ulcerative colitis also, where this sulfasalazine agent is used. So these are the names of the sulfonamides which you have to remember: short acting, intermediate acting, long acting, and some special purpose sulfonamides. So antibacterial properties. So what is the spectrum of the sulfonamides and against whom it can act? So this is known as the antibacterial properties. Basically, it is a bacteriostatic agent against the gram-positive and gram-negative both bacteria. So there may be, the bactericidal agent or bacteriostatic agent. Bactericidal directly kills the bacteria, and bacteriostatic agent just controls the proliferation of the bacteria. And in fact, it has been seen that in some of the antimicrobial agents, in different doses, they can be bacteriostatic or bactericidal. So basically, it is a bacteriostatic agent, but it can attain the bactericidal concentration in urine. That's why in urinary tract infection, sulfonamide is very good for treatment. Susceptible organisms, most commonly are Streptococcus pyogenes, Haemophilus influenzae, Haemophilus ducreyi, Calymathobacterium, Granulomatosis, Vibrio cordis, Chlamydia, and Actinomycetes, etc. So different range of the bacteria can be affected. Few strains of the Staphylococcus, Gonococci, Meningococci, Pneumococci, E. coli, and etc. can also be affected. And apart from these bacteria, some protozoas can also be affected by these sulfonamides, like Plasmodium, that is a malarial protozoa. It can be treated by the sulfadoxine and pyrimethamine combination. So this sulfadoxine is a metabolite of the sulfonamides, and it can be combined with pyrimethamine, another antiprotozoal agent, and these two can be used as a treatment for malaria. Sulfadoxine pyrimethamine combination for Plasmodium infection. Toxoplasma gondii infection that can cause toxoplasmosis, and it most commonly happens in immunocompromised persons, and cerebral toxoplasmosis occurs where the patient presents with seizures, epilepsy, etc. and can also die. And it can also be treated by sulfadiazine and pyrimethamine combination. So you can see this sulfadiazine is also a sulfonamide. And pneumocystis carinii pneumonia. PCP is the pneumocystis carinii pneumonia, and this pneumonia basically opportunistic infection most commonly occurs in HIV/AIDS individual. So those persons who have HIV infection, you will get antiretroviral therapy for HIV/AIDS later. So if those persons have CD4 count very less, those persons are susceptible to different types of the milder type of infections, be it bacterial, be it fungal, viral, etc. Of this, one of the important is the pneumocystis carinii pneumonia (PCP), and this can be treated by the sulfamethoxazole plus trimethoprim combination. So how it acts, mechanism of action? So basically, it can be explained by the Woods and Fields theory. This is important. The mechanism of action of the sulfonamides. Bacteria normally picks up para-amino benzoic acid from surroundings to synthesize folic acid. So para-amino benzoic acid is an important metabolite for the synthesis of the folic acid in bacteria. And bacteria have to gather this para-amino benzoic acid from the surroundings. So inhibition of this bacterial folic acid synthesis from PABA is the competitive, and this can be happened by the sulfonamide. And this is an essential metabolic reaction. So you can see para-amino benzoic acid plus pyridine is converted by means of the pyridine synthesis to dihydroteroic acid, and this can be blocked by the sulfonamides. So folic acid, you know, as an important ingredient for different types of the metabolism in case of the bacteria, most commonly different types of the one carbon transfer reactions, and this can be affected sulfonamide. This dihydroteroic acid is by means of the enzyme dihydrofolate synthase can be converted to dihydrofolic acid, and this dihydrofolic acid is converted to tetrahydrofolic acid by dihydrofolate reductase. And this tetrahydrofolic acid is the active constituent of the folic acid. You have already read in the iron folic acid chapter, that is the tetrahydrofolic acid. It is the important active coenzyme form of the folic acid, and that is also important for bacterial metabolism also, like that of the humans. So ultimately bacteria need this tetrahydrofolic acid, and from this pathway this tetrahydrofolic acid is formed that can be converted to thymidine, purines and ketone. That is the different types of the amino acids. So this tetrahydrofolic acid can be blocked if this pathway is blocked. Later you will see that these sulfonamides can be combined with another antibacterial agent, trimethoprim. Trimethoprim also blocked in the same pathway but in the upstream, that is in the another level. It blocks the dihydrofolate reductase. So if we combine with sulfonamide, some sulfonamide with trimethoprim, the killing of the bacteria will be more robust. That is, if we can combine these two bactericidal agents in a proper concentration, that the action will be synergistic. That is, 1 plus 1 will be greater than 2. This is known as the synergistic. Okay. So you will, I will come to this later. So this is the mechanism of action by which sulfonamides act, and where the trimethoprim acts, another agent that can be added. But the question is, why do humans usually not affected? Because we humans usually use the preformed folic acid. Usually for the synthesis of this tetrahydrofolic acid from the para-amino benzoic acid, we need some preformed folic acid. So it has also been seen that if we supply the para-amino benzoic acid from outside, that can antagonize sulfonamides. That is, our infection is occurring. Now we are giving sulfonamides, and again, if we are supplying para-amino benzoic acid from outside, it can supersede the action of the sulfonamides. That is, the action of the sulfonamide is competitive to this pathway. That is, formation of the dihydroteroic acid, lastly tetrahydrofolic acid from para-amino benzoic acid and pyridine. And its structure resembles this para-amino benzoic acid, PABA. Okay. So now it has been seen that many bacteria become resistant to these sulfonamides. Many strains, Staphylococcus, etc., become resistant. there are different types of the mechanisms. Details is not required. Just remember there will be production of the increased amount of the PAPA. Folate synthesis enzyme has low affinity to sulfonamides in some bacterial agents by the time. And an alternative pathway for folate synthesis and resistant to one sulfonamide, if happens, it becomes resistant to all types of the sulfonamides. So we know that due to the indiscriminate use of the different types of the antibiotics, different types of the infections become resistant to different types of the antibiotics. Previously, in 70s, 80s, 90s, the sulfonamides become very effective against many organisms. Now it has been seen that many organisms develop resistance. So kinetics is rapidly and completely absorbed from the gastrointestinal tract. Plasma-protein binding differs between the different agents metabolized by acetylation. So there may be slow acetylated and fast acetylated according to the genetic makeup of individuals. So the pharmacokinetics of two different individuals can differ according to the acetylation scatter. Acetylated product is excreted in urine. So if more toxic than parent compound. So if there will be more sulfonamides in our body and more metabolites are getting excreted to urine, there may be a chance of a condition known as the crystalluria. That is, the crystals of the metabolite of the sulfonamides are excreted to urine, and if it becomes more, that can block the urine flows. So crystalluria can become a problem. That's why if the patient is given sulfonylurea, the patient is asked to take more amount of the water, okay? And it is reabsorbed in tubule. So it is according to the half-life of the sulfonamides. So short-acting, intermediate-acting, long-acting, etc. So now coming to the sulfoxazole, different agents. Sulfoxazole is rapidly absorbed and excreted with excellent antibacterial property, bound extensively to plasma protein, and kidney excretes approximately 95% of the single dose in 24 hours, and the concentration of CSF is about a third of the blood. That is, this can go to the brain also. That's why if there is problem of the cerebral infections, there also sulfonamides can be used. And this sulfoxazole acetyl is now available in combination with erythromycin for use in children with otitis media. Now mostly it is used in the treatment of the otitis media. Just remember, sulfoxazole can be used in otitis media in combination with the erythromycin. Next, coming to the sulfamethoxazole. It is a close congener of the sulfoxazole administered orally and employed for systemic and urinary tract infections. So it is very good for urinary tract infection, sulfamethoxazole. And already what I am telling about the crystalluria, this is also very much present with sulfamethoxazole. So sulfamethoxazole crystalluria can happen if there is more acetylated derivatives is present in the urine. So clinical use of the sulfamethoxazole same as that of the sulfoxazole. That is in otitis media in urinary tract infection. Coming to the sulfadiazine. Sulfadiazine is absorbed rapidly from the gastrointestinal tract and peak blood concentration reaches within 3 to 6 hours. Both free and acetylated forms are available in our body, and it also needs the alkalinization of urine again for the same crystalluria. If we are taking much larger amount of the water, or if we are alkalinizing the urine by means of different alkalinizing agents, that will help resolve the problems of the crystalluria. So every precaution must be taken to ensure fluid intake adequate to produce a daily urinary output of approximately 1200 ml in adults and corresponding quantity in children. So both in adults and children, it has been asked to bring more amount of the water, and if there is any problems in the urination, we have to give the alkalinizing agent. If this cannot be accomplished, that is, if there is problem, alkalinizing agent like sodium bicarbonate may be given to reduce the risk of crystalluria. So remember, for sulfadiazine, sulfamethoxazole, sulfoxazole, or internally for the sulfonamides, crystalluria is a problem, and for this crystalluria, the patient is asked to drink more amount of the water. If it does not resolve, then different alkalinizing agent like sodium bicarbonate is given. Now coming to the sulfosalazine. The previous three sulfonamides have been shown to be very good absorbed from the gastrointestinal tract, but this sulfosalazine is very poorly absorbed from the gastrointestinal tract. It used mainly in the therapy of the ulcerative colitis and regional enteritis. So basically, it is used in inflammatory bowel disease like ulcerative colitis and regional enteritis. Intestinal bacteria basically break the sulfasalazine to 5-aminosalicylate, and the active agent in the inflammatory bowel disease and sulfapyridine. Sulfapyridine is a sulfonamide that is absorbed and eventually excreted into urine. So basically, this is the breakdown agent, 5-aminosalicylate and sulfapyridine, and by this the sulfasalazine acts. Next, coming to the sulfacetamide. Sulfacetamide is basically a derivative product of the sulfanilamide. It is used mainly in the management of the ophthalmic infections because its concentration in the aqueous humor of the eye becomes very high. So very high aqueous humor concentrations are not irritating to the eye and are effective against susceptible microorganisms. So sulfacetamide drops are available. It can be used for ophthalmic infections. The drug penetrates into ocular fluids and tissues in high concentrations. So remember, sulfacetamide penetration to ocular tissues is very high. That's why it is used in ophthalmic infections. Sensitivity reactions are also very rare, and ultimately there is very less hypersensitivity. So sulfacetamide, management of the ophthalmic infections. Next, coming to the silver sulfadiazine. Silver sulfadiazine is basically used as a cream or ointment, that is the topical agent, to reduce microbial colonization and the incidence of infections from burns. So when the burns happens, usually in the first degree or second degree burns, there is more chances of the infections because the upper layer of the skin becomes lost. So here the silver sulfadiazine acts very well. Antibacterials should be used, not the topical agent. So silver is very slowly from the preparation in concentrations that are selectively toxic to the microorganisms. And bacteria may develop resistance to silver sulfadiazine. So adverse reactions are burning, rash and itching, and it is considered an agent of choice for the prevention of burn infection. So silver sulfadiazine, it can be used for the burn infections. Both the silver as well as the sulfadiazine component both help in the treatment of the burn, okay, and prevents the burn infection. Methionine is another agent that can also be used topically, and it inhibits the carbonic anhydrase and the urine becomes alkaline. So the problem of the metabolic acidosis with compensatory tachycardia and hyperventilation are there. So that is the problem. That's why methionine is lesser used now. So next, coming to the sulfadoxine. So sulfadoxine is basically used in the treatment of the malaria. Sulfadoxine pyrimethamine combination is normally used. Prophylaxis and treatment of the malaria caused by microbial resistant strains of the Plasmodium falciparum. This is the indication now. So microbial is another antimicrobial agent. You will read later. So some Plasmodium becomes resistant to this, where this sulfadoxine can be used. So clinical use, sulfonamides are infrequently used as single agent. The fixed-dose combination of the trimethoprim sulfametoxazole is the drug of choice for infections such as pneumonia, toxoplasmosis, nocardiasis, and obviously other bacterial infections. Adverse reactions are lesser. There may be some allergic adverse reactions because these sulfonamides becomes allergic to sulfur. So fever, skin rash, exfoliative dermatitis, photosensitivity, euphoria, nausea, vomiting, diarrhea, all can happen, and it may also cause stomatitis, conjunctivitis, etc. But in the most severe cases, there may be deepening of the skin. Skin may be peeled off, and this is known as the Stevens-Johnson syndrome. So Stevens-Johnson syndrome can happen in some rare cases of the sulfonamide allergy. Urinary tract disturbances, already discussed about the crystalluria in large doses. So when sulfonamide is given in large doses, crystalluria can happen. Nephrosis and allergy, nephritis, that is the problems in the kidney can also develop. Hematopoietic disturbances like aplastic anemia, granullocytopenia, thrombocytopenia can happen, and it can provoke a hemolytic reaction in some individuals who have glucose 6-phosphate dehydrogenase deficiency. So there may be some individuals who have P6PD deficiency. This is more prevalent in some Mediterranean regions where if the sulfonamides is given, the breaking down of the RBC will happen. This is known as the hemolytic anemia. At end of pregnancy, it should not also be given because the is the risk of kernicterus. Kernicterus is deposition of the bilirubin in the basal ganglia. That can happen in the newborn. So it should not be given in the latter part of the pregnancy. Now coming to the 4'-oxazole, that is the most important. So 4'-oxazole, already we have seen that if we can combine these sulfonamides with trimethoprim, that can have a synergistic action. It was invented in 1969, which is a fixed drug combination of the sulfamethoxazole and trimethoprim. So trimethoprim, what is this trimethoprim? It is basically a trimethyl enzyme pyrimidine, chemically related to the pyrimethamine. And do not confuse 4'-oxazole is the, you can see, sulfamethoxazole and trimethoprim combination. These are very important. So 4'-oxazole is trimethoprim sulfamethoxazole. But we have already discussed sulfadoxine plus pyrimethamine, which is anti-malaria. So 4'-oxazole is the sulfamethoxazole and trimethoprim combination. And for anti-malarial agents, we have to use the sulfadoxine and pyrimethamine combination. So how it acts the sequential blockade. Already we have seen this trimethoprim is approximately 50,000 or more times more active against the bacterial dihydrofolate reductase enzyme than the mammalian dihydrofolate reductase enzyme. So we have also dihydrofolate reductase enzyme that converts the dihydrofolate to tetrahydrofolate, but these are more effective against 50,000 times more effective against the bacteria and very less effective against our own dihydrofolate reductase. Individually, both this trimethoprim and the sulfonamides are bacteriostatic, but the combination is the bactericide. So this is very important. Why these two are combined? The mechanism of action in the two steps they are used. They are basically used in the same pathway, but in the two different enzymes level, so that these two are individually bacteriostatic. But when these two are combined, they attain the bactericidal concentration. So usually given orally alone or in combination with sulfamethoxazole, can also be given intravenously. While also from the gut, trimethoprim is more lipid soluble than sulfamethoxazole and concentrates in prostatic fluid and vaginal fluid. So that's why if there is some prostatitis or vaginitis, that is also very effective, this combination. So you can see trimethoprim and sulfamethoxazole together show greater inhibition of the bacterial growth. This is the number of bacteria in arbitrary units. Okay, AU. And this is the hour. When these two are combined, when there is more drug, there are more bacteria. Only sulfonamide, only trimethoprim alone, and sulfamethoxazole alone, you can see. But when these both drugs are combined and violet ones, there will be more killing of the bacteria. You can see the bacterial load is very low. So by this drug, you can see how the bacterial load can be controlled when these two drugs are combined together. So why these two are combined and how it is combined? So these both of drugs, trimethoprim and sulfamethoxazole, have almost similar half-life. So both have 10 hours half-life. That's why they have similar types of the pharmacokinetics. So they can be combined. Optimal synergism is obtained when in the plasma 20:1, 20 sulfamethoxazole and 1 trimethoprim concentration is achieved. This is basically a minimum inhibitory concentration is reduced by 5 to 6 times. So in the plasma, this 20:1 concentration, if it is there, that ultimately causes killing of the many bacteria. And this 20:1 concentration in plasma can be obtained if we are concentrating the original drug in the 5:1 ratio. That is 800 mg into 160 mg. So basically, because trimethoprim has large volume of distribution and enters many tissues, so plasma concentration is low. That's why if we are combining this into 5:1 ratio in the plasma, it will reach to 20:1 ratio because the trimethoprim has large volume of distribution than the sulfamethoxazole and it enters many tissues. So in many tissues where there are bacterial infections, that will be killed. So it is clear. So for the killing of the bacteria, we need 20:1. 20 sulfamethoxazole is to 1 trimethoprim concentration in the plasma. It is the plasma concentration of the killing of the bacteria. And for this 20:1 concentration to achieve, we have to combine in the tablet, the original tablet, in this ratio 5:1. 5 sulfamethoxazole, 1 trimethoprim. Because the trimethoprim, when it enters within the body, it has large volume of distribution, it enters many tissues. That's why its concentration ultimately increases and it reaches 20:1. Okay. And trimethoprim crosses the blood-brain barrier and placenta of sulfonylurea not, so the combinations can be used if there is some infections in the cellular. Trimethoprim is more rapidly absorbed than sulfonylurea. It is 45% plasma protein bound plus sulfonylurea 65%, and it is partly metabolized in the liver. So antibacterial spectrum similar to sulfonamide. Additionally, it is effective against the salmonella typhi, that is the typhoid that causes the typhoid. Serratia, Klebsiella, Enterobacter, Yersinia, and Pneumocystis jirovecii or Pneumocystis caridii. That is already discussed. Pneumocystis caridii pneumonia. Sulfonamide resistance traits happen, but it is less. Resistance is slow to develop than the sulfonamide by mutational changes of plasmid mediated way. So this is the bacterial spectrum. So originally all the bacteria are different gram positive and gram negative that are sensitive to the sulfonamides, as well as different other important ones like typhoid, Serratia, Klebsiella, Enterobacter, Yersinia. Yersinia pestis causes plague. That's why for plague it is an important agent. Pneumocystis caridii pneumonia as well. So why it is used? Uncomplicated infection of the lower urinary tract, like cystitis, chronic and recurrent urinary tract infections. It is used. Respiratory tract infections like lower and upper chronic bronchitis, faciomexillary infections, otitis media due to gram-positive cocci and Haemophilus influenzae. Typhoid, already I discussed. So for typhoid it is an important agent. Bacterial diarrhea and dysentery due to Campylobacter, E. coli, Shigella, etc. Pneumocystis jirovecii pneumonia, severe pneumonia, prophylactic use of the AIDS patient with neutropenia. Xanthoid is caused by Haemophilus ducreyi. So xanthoid is basically a sexually transmitted disease. So this can be treated by the cotrimoxazole also, alternative to penicillin in acanthocytosis patients and septicemia. So these are the uses of the cotrimoxazole. Very important cotrimoxazole, that is short note, a long question or in fiber. Why it is combined? What are the benefits of the cotrimoxazole? What are the antibacterial spectrum? And what are the uses of the cotrimoxazole? So, within the urinary tract infections, treatment of the uncomplicated lower UTI, it has been given. Usually the combination is used. Trimethoprim, details is not required. Remember, for urinary tract infections, cotrimoxazole is an important agent. Bacteria respiratory tract infections, it is also an important agent, but it should not be used to treat the streptococcal pharyngitis because it does not eradicate the microorganisms. Because why this eradication is important? Because this streptococcal pharyngitis, if eradication does not happen, that can reach to the heart and rheumatic heart disease can happen. This is also known as the rheumatic heart disease. Rheumatic heart disease can happen if the sulfonamides or cotrimoxazole is given in the pharyngitis. So it should not be given in pharyngitis, it should be given in other respiratory tract infections. Gastrointestinal infections, it can also be given, details is not required, and infections by Pneumocystis jirovecii. That is the Pneumocystis caridii pneumonia. Same thing, that it happens in HIV individuals or AIDS individuals or neutropenic individuals who are immunocompromised, and cotrimoxazole, remember, is an important agent for still now. It's an important agent for treatment of this opportunistic infection. Prophylaxis in neutropenic patients, the same thing. So neutropenia is where the neutrophil count becomes less. This may happen due to chemotherapy in the cancer or due to other immunocompromised agent use, and in all these cases, cotrimoxazole can be used. And apart from this, miscellaneous infection like nocardial infection, it can be used. It can be used in the Whipple disease. Whipple disease is a gastrointestinal infection which is caused by Clostridium whipple, infection by Pneumocystis maltophilia, infection by intestinal parasite Cyclospora, Isospora. So these are the different minor types of the gastrointestinal infections where the cotrimoxazole can be used. Apart from this, Coagna granulomatous is a connective tissue disease where it can also be used. So you can see in a nutshell, so different types of the agents, these gram-positive cocci, gram-positive bacilli, Staphylococcus, Listeria, gram-negative cocci and rot, E. coli, Haemophilus influenzae, Proteus, typhi, anaerobic organisms, Pyrobis, Jirovecii, Toxoplasma gondii, all by this 4'-oxazole. And you can see it can be used in MRSA, that is the medicine resistant staphylococcus. That is because different types of the resistant organisms have emerged. Why this 4'-oxazole can be used? Respiratory tract infection, pneumocystis bullosa pneumonia, listeriosis, prostate and urinary tract infection, prostatitis, UTI, etc. Gastrointestinal infection. In all these cases, it can be used. So this is very important. The antibacterial spectrum. What are the indications of the 4'-oxazole? Adverse drug reactions, more or less. All adverse drug reactions of the sulfonamides can be there. So it should not be given in pregnancy. That is important because there is teratogenic risks. Neonatal hemolysis, beta-hemoglobin can happen. In elderly, risks of bone marrow toxicity is there, and bone marrow hyperplasia in age patient can also be there. So this is the more important agents. But other than this, there is very less adverse drug reactions with the 4'-oxazole. So thank you. We will come to another one. Actinomycin. Remember, this is important. So chlortetracycline is the first one which was invented in 1948. After that, oxytetracycline came. A new synthetic subclass is dicyclin has also been there. Of which the tetracycline is an agent. So why these agents are called broad spectrum? This is very important for your exam also. Why is tetracycline and chloramphenicol are known as the broad spectrum antibacterial agents? So name is given as a contrast to the existing antibiotics at that time. At that time, existing antibiotics were penicillin and streptomycin. This penicillin and streptomycin is a narrow spectrum. Narrow spectrum means that can only act against the gram-positive or gram-negative organisms or cocci or bacilli. But when it is from the soil actinomycetes, different tetracyclines are developed or chloramphenicol are developed. It has been seen to be effective against a large group of organisms. So wide spectrum of activity. It is active against the gram-positive cocci, gram-positive bacilli, including anaerobes, gram-negative bacilli, including anaerobes, spirochetes, rickettsia, chlamydia, intermittent histolyticum, plasmodium. So you can see these are the miscellaneous bacteria. Spirochetes, rickettsia, chlamydia, very lesser affected by other antibacterial agents. So that's why it is known as the broad spectrum antibiotic agents. But the problem is due to the injudicious use, most of these broad spectrum antibiotics become resistant to many organisms. That's why it is used in selected cases. So tetracyclines. So tetra, that is why there are 4 rings. So class of antibiotics named for the nucleus of the 4 hydrocarbon rings. 4 hydrocarbon rings are there. All are obtained from the soil actinomycetes. It can be divided into either naturally occurring or semi-synthetic. Naturally occurring tetracyclines are tetracycline, chlortetracycline, oxytetracycline, and dimethyl. Of this, chlortetracycline is not now used nowadays. Tetracycline, oxytetracycline, dimethyl is used. Within the semi-synthetic, doxycycline, minocycline, and ilicycline. These 3 are not used now. Of this, you can see that doxycycline is very important agent. During the corona times, COVID times, you can see that many patients ultimately cured by usage of the doxycycline. Okay, so doxycycline is basically a tetracycline, derivative of tetracycline. It can again be divided into short-acting, intermediate-acting, and long-acting. Short-acting is tetracycline, oxytetracycline. Intermediate-acting is dimethyl, limecycline. Long-acting is doxycycline and minocycline. According to the EHA, whether 6 to 10 years, or 12 to 13 years, or 18 to 20. So basically, the previous ones, the tetracycline, dimethyl, they are of lower potency, primarily excreted to the kidney, and the newer ones like doxycycline, minocycline, ilicycline, they are of higher potency, lipid soluble, long acting, excreted to liver, completely absorbed from the stomach. So tetracycline, how is tetracycline act? So tetracycline is basically again a bacteriostatic agent. You have already read in the biochemistry about the translation of the bacterial protein. So within the bacterial protein, there are different steps. One of the steps is the binding of the 30S ribosome and the amino acid mRNA complex. This complex is an important part of the new protein synthesis in bacteria. This tetracycline inhibits the bacterial protein synthesis by binding to these 30S ribosomes. So there are 2 components of the ribosomes. Of this, tetracycline binds to RPS ribosomes, the amino acid tRNA to mRNA ribosome complex has interfered or blocked, and ultimately the peptide chain fails to grow. The synthetic organisms are basically an active transport process. By means of active transport process, tetracyclines are captured within the bacteria. In gram-negative bacteria, it diffuses to foreign channels also. The more lipid-soluble ones can enter by passive diffusion. Two factors are responsible for the CLP toxicity of the tetracyclines. One is the carrier. Carrier is there for the tetracycline capture, and protein synthesizing apparatus of our cells, host cells, are less susceptible. That's why it becomes less toxic to us. Resistance is developed some greater manner, and in some of the organisms, resistance has developed. The antimicrobial spectrum, it is basically a bacteriostatic drug. Originally, all types of organisms except some virus and fungi are susceptible. Different types of the cocci and bacilli and enterobacteriaceae, including the Pseudomonas, Klebsiella and Salmonella, because these three become resistant to different other agents. In some of these cases, this tetracycline derivative like doxycycline can be used. So broad spectrum different agents it can be used. Adverse effects are lesser GI disturbance can occur due to irritation, but the problem is super infection because they have broad spectrum, so disturbance in the normal flora. So within our gastrointestinal tract, there are some commensal bacteria. These can be killed by these tetracyclines also. So super infection with other agents like candida that can lead to candidiasis, staphylococcal enteritis by means of the staph aureus, or pseudomembranous colitis that can be caused by Clostridium difficile. Can happen. Of this pseudomembranous colitis infection due to super infection is very dangerous. That can lead to perforation of the gut and can lead to death also. And difference of the diarrhea, how it can differ between this pseudomembranous colitis, diarrhea and other diarrhea. So causes or RBC can be present in this diarrhea, but it will not be present in other types of latent diarrhea. Liver damage, kidney damage, phototoxicity can happen. Of this, the important is the phototoxicity. All these tetracyclines are susceptible to sunlight, and ultimately that leads to skin rashes, erythema, brown black discoloration of the nail, loosening, and within the teeth and gums, it can also lead to discoloration. So brown discoloration can happen because this tetracycline binds with the other agents, so calcium tetracycline chelate can be formed. So deciduous teeth can be affect the crown of the permanent anterior dentition, and in pregnancy and childhood it can lead to temporary suppression of bone growth. That's why it should not be given in pregnancy, it should not be given in children also, because they can hamper the bone growth, they can hamper the teeth. Okay. So it can be used in empirical therapy in mixed infections. So different types of the infections are there. Rickettsial infection, atypical pneumonia, brucellosis, plague, bubonic and pneumonic plague. In plague also it is an important agent. Apart from this, urinary tract infection, some falciparum malaria, amoebiasis, community-acquired pneumonia, active vulgaris, COPD, it can be used. So these are the uses of the tetracycline. Pedicycline is a newer agent that can be used intravenously, mainly used in treatment of serious and hospitalized patients of community-acquired pneumonia. So community-acquired pneumonia or the patient is already in the ventilation, already present in the hospital in those cases. Complicated skin and skin structure infections, complicated intra-abdominal infections caused by enterococci, anaerobic and enterobacteria. So in these cases, pedicycline, which is a derivative of these tetracyclines, can be used. This is basically a glycine, but it is not recommended for hospital-acquired infections. It has been seen to be high mortality. It is not suitable for urinary tract infection. It is only used for community-acquired pneumonia, complicated skin infections, and complicated intra-abdominal infections. These three, remember, that pedicycline. Lastly, coming to the chloramphenicol. So chloramphenicol is obtained from the Streptomyces venezuelae, which is another organism from which it can be used. This is the chemical structure. Now, all the chloramphenicol obtained are the synthetic products. They have nitrobenzene ring, which have antibacterial properties. So the antibacterial property occurs due to this nitrobenzene ring. The mechanism of action is again interfering protein synthesis. They interfere with transfer of the elongating peptide chain to the newly attached amino acid tRNA to the ribosome mRNA complex. So this attaches with the 50th ribosome. Tetracycline attaches with the 30th ribosome. It attaches with the 50th ribosome and blocks the peptide elongation. So you can see, so different types of the antibacterial agents act at the different levels of the protein synthesis. You have already read this in the biochemistry, just revise this. So these are the steps. These are the steps of which you can see the two. This is the area where the tetracycline acts. So tetracycline acts at the 30th ribosomal subunits and inhibits the amino acid tRNA attachment. You can see this is the attachment to the A site, acceptor site. So this is the peptide site, this is the acceptor site. The attachment of the amino acid tRNA to the acceptor site is inhibited by the tetracycline, and chloramphenical is the 3. This binds to the 50S ribosomal subunit, interferes with the peptide bond formation and the transfer of the peptide from this peptidyl site to the acceptor site. So you can see, so this is the area where the tetracycline acts. This is the area where the chloramphenical acts. You will read the other antibacterial agents also act in different levels. So here the tetracycline acts, here the chloramphenical acts. Chloramphenical attaches with the 50th ribosomal subunit. It interferes with the peptide bond formation and transfer of the peptide chain from the peptidyl site to the acceptor site. Okay. So basically, it is a highly effective against Salmonella typhi. Until 1980s, the chloramphenical is the main agent for the treatment of the typhoid. But now, most the Salmonella typhi becomes resistant to the chloramphenical. Now it is more effective against the Haemophilus influenzae, Bordetella pertussis, Neisseria meningitis, less active against gram-positive cocci spirochetes, and it is not effective against the chlamydia, entamoeba, and plasmodium. Again, the resistance developed and the mechanism of resistance mainly are plasmid. So plasmid mediated resistance of the chloramphenical happens. That's why chloramphenical previously it is very much susceptible to different organisms. Now mostly it becomes resistant. Adverse effects. This is also an answer. That's why it is used. Many of the chloramphenical ultimately leads to bone marrow depression in many individuals. So it is a notorious causes aplastic anemia, agranulocytosis, thrombocytopenia. That is when it is given in some individuals, the blood corpuscles becomes compromised. That's why these may be non-dose related or dose and duration related. Non-dose related because it is rare, unpredictable but severe. Aplastic anemia. That is from the bone marrow different RBC, WBC platelets are not growing that it should be grown. So non-dose related idiosyncratic reactions can happen, and dose and duration of therapy related myelosuppression. So if it is given for longer duration of time or larger doses, that also leads to aplastic anemia or thrombocytopenia, etc. So remember, bone marrow depression is an important adverse effects of the chloramphenical. Apart from these irritative effects and hypersensitivity is there. And within the children, within the newborns, another important adverse effect is the Gray baby syndrome. This is also an important for your exams. So Gray baby syndrome develops 2 to 9 days after dose of approximately 100 mg per kg. Within 24 hours, the baby starts to vomit, stops eating, rapid and irregular respiration starts, abdominal distension happens, periods of the cyanosis and loose green stool happens. So in case of the children, previously chloramphenical is used, and chloramphenical is also effective in different types of the childhood infections also. But the problem of the Gray baby syndrome is there. Baby then can turn to ashen grey color and becomes flashing and hypothermic. The temperature becomes less. Also can occur in adults who are cirrhotic. Death in 40% of the cases due to cardiovascular collapse, and due to this happens due to inability to metabolize and excrete chloramphenical. So within the adverse effects of chloramphenical, remember in case of the children, Gray baby syndrome can happen within 2 to 9 days after dose of 100 mg per kg. So why it is used? Enteric fever mainstay in the past, but very less used nowadays. Meningitis, it is now mainstay. As second line to third generation cephalosporin. You will read the cephalosporins later. Cephalosporins, third generation cephalosporins out of the indication of the choice. But if it is not used, it is not responding to chloramphenical is given. Meningococcal meningitis, Haemophilus influenzae, anaerobic infections like bacterial vaginitis, intraocular infections like endophthalmitis can be used, and it can be used as second choice agent, second brucellosis, urinary tract infection, rickettsial infection, conjunctivitis, external ear infections also. So this is all about the tetracycline and chlorphenicol. So within this, within the sulfonamides, the important one of the different names of the sulfonamides, what are the long-acting, short-acting, intermediate acting. Okay. Next is the what are the sulfonamides that can be used as topical agents in burns. What are the sulfonamides that can be used in inflammatory bowel disease? What are the sulfonamides that can be used in the treatment of malaria? These three are very important for your MCQs, for your IVs. And then coming to the combination, that's the cotrimazole, very important for your short notes, fiber, etc. Important why the cotrimazole, these two are combined. Why this is combined? The pharmacokinetics, what are the ratios it should be combined, etc. And what are the indications why this cotrimazole is given. Within the broad spectrum antimicrobials, tetracycline, chlorphenicol, the mechanism of action mainly in the protein translation machinery. The important question is why these are called broad spectrum antibiotic agents. Very important for your fiber. Why chlorphenicol is lesser used now? One is resistance due to arthrosmic. Next is different types of the adverse effects. Most commonly the bone marrow suppression. Bone marrow suppression, aplastic anemia, that can be dangerous. That may be dose related or non-dose related. This is important because non-dose related. Because if we know that this is a dose-related adverse effect, we can increase the dose. But for chlorphenicol, non-dose-related adverse effect can also happen. That is, for a very tiny doses of the chlorphenicol can also lead to disastrous consequence of the aplastic anemia. And in children, that can lead to grave syndrome. So this is all about it. Thank you.